2030, obesity will be initiate about 30% of the deaths. WHO has said simplistically that the fundamental cause of obesity and overweight is an energy imbalance between calorie intake and calorie expended. And it's the most simplistic measure is, of course, the BMI. When we are talking of obesity, we should know a few of the units and classifications. BMI is basically weight in kilograms divided by height in meters to the power of square. And the various parameters, the waist circumference was in vogue a few decades back for obesity, and we can see here that for the Asian population, this population is different. It's more stringent. More than 90 centimeter in men and more than 80 centimeter in women is considered to be pathological. So we can see that Asians are at a higher risk, and hence the criteria is much more stringent for the Asian population. The WHO classification according to BMI is underweight less than 18.5, normal is 18.5 to 24.9, and obesity is classified into 3 classes by class 1, class 2 and class 3. This is the heterogeneous subtypes of obesity as has been defined by WHO. The first is the metabolically healthy obese. The second subtype is the metabolically abnormal obese. The third is the metabolically obese normal weight individuals. And the fourth option are the sarcopenic obese individuals. So these are the heterogenic subtypes which are more of a theoretical use, not of much practical value. It's highly prevalent. The figures in India, though these are old figures of 2018, the prevalence is about 1 in 16 in women and 1 in 25 in men, but I am sure that figures are worse now, and the global figures are not too good either. And there are various causes of obesity. There are health factors, environmental factors, social factors, lifestyle behavioral, but the most common we see is the childhood obesity these days, and the tech obesity which we are seeing in the work from home culture which we are seeing for the last 2-3 years, especially in the IT sector. So these are the the types of obesity which are coming up. Now, what are the pathomechanisms? It's very simplistic to understand that it's just an energy imbalance, but the mechanisms is much more complex. There is an intricate interplay between genetic, environmental and psychosocial factors. Studies on twins and families have shown that the BMI heritability is to the tune of 40 to 70%. So there is a strong genetic component. Research into monogenic obesity has underlined the importance of biomolecules in the body in the pathogenesis, and energy balance is seen to be controlled by complex interactions between the central nervous system, adipose tissue, gut, liver, pancreas and various other organs. So it's much more complex than it's thought. Some hypotheses about the different molecules in the body which decide whether the person will become an obese or not, like leptin, then there is insulin, there are endocannabinoids, there is propiomelanocortin, neuropeptide Y and AGRP, then agouti related peptides and ghrelin. These are some of the molecules, biomolecules which are thought to affect long term energy balance and hence predispose a patient to obesity. But whatever be the cause, whatever be the mechanism by which the patient becomes obese, the ultimate factor is that it's associated with a large number of metabolic disorders, whether they are mental disorders or cardiovascular disorders, malignancies, metabolic diseases, coagulation disorders, skin diseases, musculoskeletal, reproductive, pulmonary diseases and urogenital diseases. So we can see that it affects all the organs of the body. It affects and it can lead to a large number of metabolic disturbances in the body. So when we know how prevalent obesity is and how dangerous it is, naturally we should talk about management, and that's the main part of my talk. So management is basically, we can divide into 2 different aspects. First, the management at the individual or personal level and the management on the social level. So we all talk about management of the individual level, but when I was preparing my slides, I found a very interesting article regarding management of obesity on a social level. There was an article, there was a publication in eClinical Medicine, systemic review into city interventions to address obesity. It studied the interventions done by the different municipal corporations of the city across 24 cities around the globe, and it was a very interesting finding. They compared which city governance has done what to curb obesity, and in a nutshell, This showed the various community interventions like school programs of education and support for children, as well as teachers and parents and caregivers on healthy eating habits and increasing physical activity, then restricting unhealthy food provision and advertising around schools, and increasing the provision of free healthy school meals. Then there was a banning of unhealthy food advertising on public transport and unhealthy food or drink sponsorship of various sports events. Then certain cities did a mandate on calorie labeling at fast food restaurants, and they conducted workshops or health education booths on weekends, which gave the children information about nutrition and food labels and how to decode the food labels, how to understand which food is good and which is bad. Then there was multi-level, multi-component intervention to increase the availability and demand for healthier food, and then limit restaurant portion sizes of most sugar-sweetened beverages. However, this was also mentioned that Toronto was the first city to start this, but they failed miserably. All the restaurants united to oppose the government on this fact. This measure finally failed, that they should limit restaurant portion sizes of most sugar-sweetened beverages and restrict consumption of sugar drinks. Then there was a voluntary partnership approach to change children's menus through removing sugar-sweetened beverages and increasing fruit and vegetable offerings. And then education and support programs, including media campaigns regarding good eating habits and regular exercise. And of course, last but not the least, infrastructure development of the cities, development of parks, sidewalks, walking trails, bike lanes, and apartment and community sports facilities, making those compulsory in all apartments as a rule to make gyms and other sports facilities. So these are certain measures which have been done globally by different city administrations, and that was a very interesting read. Now coming to the level in the management of obesity at the individual level. So any management of obesity starts with behavioral modification. We can't just advise and write any 1, 2, 3, any medications to treat obesity, unlike any other disease. Here the first and foremost is to counsel the patient, to convince him that he is obese, number one, not to shame him, number two, and to convince him of the advantages of reducing obesity. So that is the most important part of treating obesity, and that's where the difference lies in treating obesity as compared to other diseases. Here the treatment is more of non-pharmacological type. Pharmacological therapy is the last to be done. And the first and foremost thing I would request everybody to take home is, don't ever hurt the patient's self-esteem, even if he is obese or she is obese. There should not be any shaming on the part of the treating physician. A patient has come to you with some confidence that you will give him some sort of succor, some sort of remedy for his ailment. He or she is already shamed in the society right from childhood if he is overweight. So that is not expected from a healthcare worker, healthcare physician. And the words of encouragement and hand-holding is very important. It's needed from the physician's part. Then we should keep a very realistic weight loss goal. It should be about 5 to 7% of body weight. More overweight people underreport what they eat. So we should keep in mind that whatever the patient reports, it's highly likely that patient eats much more than that. The 5 A's of treatment, 5A model is assess, advise, agree, assist, and arrange. That is a worldwide model which can be used by primary care physicians. And the 3 approaches to obesity management are diet, exercise, and behavioral modification. Those are the 3 primary pillars of treating obesity, and they should be done if the patient's BMI is more than 25. We should remember that depression is a major component of obesity, and that should be tackled whenever we are dealing with the patient of obesity. This is a simplistic 5A model, what needs to be done. And then coming to the next part is basic dietary intervention. It's basically consists of 4 types: energy-based interventions, macronutrient-based interventions, where you target the individual macronutrients like carbs, proteins, or fat in the diet. Then dietary pattern interventions, which restrict or favor specific foods, and time restriction of meals, which includes the recent concept of intermittent fasting, or having a heavy breakfast and skipping the nighttime dinner. And of course, there are certain fads like the SNAP diets, which is very common in the TikTok and on the internet these days. There are certain fads we should always keep in mind, and we should train our patient to desist from going for them. They should avoid that and go for a scientific treatment. Diet, the basic disclaimer is diet should be rich in vegetables, fruits, and low fat. Dairy products, lower in saturated fat, red meat, sweets, and sugar-containing fruits. Fat should constitute less than 10% of energy, aiming for 300 mg dietary cholesterol per day. Fiber should be around 14 grams per 1000 kilocalories of food. And the pediatric population can benefit from learning how to use portion control and increase activity in school. Dietary fat, a low-fat diet often contains high carbs, so that should be looked about. And type of fat is more important. We should go and try to avoid trans fats. This one. This mic. Isko. I'll use this mic, right? Use the podium mic. And high protein diet improves satiety. There's a greater thermic effect. There's improved body composition. And we should try to replace red meat and processed meat with nuts, beans, fish, and poultry. Carbs quality is more important. We should go for slow carb foods like whole grains and fruits and vegetables instead of simple sugars and starches. Dietary pattern is also important. We should judge whether the patient follows which pattern, Western dietary pattern, the traditional Indian pattern, or follows the Mediterranean pattern. And breakfast, meal frequency, snacking, in between meal snacking is also very important. And we should always take a proper history of this. And yes, portion sizes need to be taught to every patient how much food is to be needed. This is a simplistic food pyramid. We should take more of fruit, vegetables, and least of sweets and meats. And the simplistic explanation is 1 palm serving of protein, 1 fist of vegetables, 1 cupped hand of carbs, and just 1 thumb of fats. That is a minimum thing. Physical activity, we can reduce risk for all metabolic diseases. It's advocated that we should do at least 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous intensity aerobic activity. And it should always be mixed with isometric activities also, muscle strengthening exercises at least twice a week. So this combination of aerobic and isometric activity should be followed. And lastly, when diet and exercise are not sufficient, BMI is still very high and patient has comorbidities, then pharmacotherapy is of course the last option. It has to be done when therapeutic interventions based on lifestyle have shown only modest results. International guidelines recommend that a pharmacotherapy should be initiated when the BMI is more than 30 or more than 27 kilogram in the presence of cardiometabolic obesity-related risk factors or complications. This criteria is lower in Asians, the BMI more than 27 in normal or BMI more than 25 in patients with complications. Again, showing that we Asians are more at risk of developing obesity-related complications. Pharmacotherapy basically works by enhancing satiety, inhibiting hunger, and increased catabolism. Currently, there are 6 anti-obesity medications advised by US FDA. Basic principles of pharmacotherapy which we need to understand is that the lifelong treatment is needed. Neurohormonal adaptation leads to weight regain and lowering of the BMR. So the patient should be encouraged to keep on exercising properly, because otherwise his BMR will come down and he'll again regain his weight. Treatment benefits both weight and comorbidities, so that should be explained to the patient that not only he will reduce his weight, he will also reduce his chances of developing other diseases like diabetes and cardiac diseases. And we should always expect heterogeneity in weight loss. There may be non-responders, there may be responders to the tune of 20% even. So all type of patients are present. The reason is still not known. These are the various US FDA approved medications. I would not go into the detail, but some of the important medications are lorcaserin was the first, but however it was withdrawn because it was found to be carcinogenic. Then SGLT2 inhibitors are there, SGLT2 dual inhibitors are there, orlistat is there. Phentermine plus extended release topiramate has been used. Bupropion plus naltrexone combination has been used. And now recently liraglutide and oral semaglutide are in vogue as anti-obesity drugs. There are then potential pharmacotherapeutical targets like polyagonists of incretin system, amylin mimetics, leptin analogs, renin vaccine, cannabinoid antagonists, antioxidants like lipoic acid, procyanidins in cinnamon or catechins in green teas. These are the potential pharmacotherapeutic targets which are being studied. There are very promising treatment under evaluation like chronotherapy, novel DDS, then gut microbiome and their distribution, prebiotics, fecal microbiota transplantation, anti-obesity vaccines and gene therapy. These are the promising treatments which are still under evaluation. There are certain herbs which are shown to be beneficial like nigella, hibiscus, ilex, rosemary, coffea, aframom, ginseng, Cattanuma, capsicum, and gingiber from ginger. These are the certain herbs which are shown to be beneficial in treating obesity. There are various novel and emerging obesity therapies which I won't go into detail. And finally, the last and the strongest treatment of obesity are the bariatric surgery, which is the last resort in case of morbid obesity. The various surgeries are gastric balloon or bypass or gastric band, or now robotic gastric bypass is being done very frequently. So these are, in a nutshell, the various treatments of obesity. The present understanding of obesity is still exercise, diet, and lifestyle changes are the mainstay of treatment. They are the three pillars on which management of obesity stands. And in tandem, when we are using all three of them, we can prevent development of obesity right at the bud. We can nip it at the bud instead of talking about treating obesity after it happens. And healthcare professionals should teach individuals about risk associated with obesity, counsel how to eat healthier, refer to community programs that offer physical activity programs. Most importantly, there should be hand-holding and motivation on the part of the physician. That is the thing for which a patient is coming to you. Otherwise, he could have got the same advice from anybody in the society. Pharmacotherapy to be planned only if the above measures fail, because any pharmacotherapy entails long-term treatment, which naturally entails risk factors and side effects. And it has to be planned when measures fail or there is comorbidity. Bariatric surgery should be reserved for morbid obesity, that means a BMI of more than 37.5 or more than 32.5 in presence of diabetes or comorbid conditions. Ongoing clinical studies will determine whether more efficacious drugs than semaglutide and tirzepatide might achieve efficacy comparable to bariatric surgery. Probably then treatment of obesity will be easier and less risky than that. What is the way forward? What we see in the future is then what can be planned in the future is that children right from their toddler age can utilize games to learn how to use portion control and physical activity. Parental involvement at the school level with lifestyle changes in the home is essential to have successful outcomes. We should learn how to prepare healthy meals, and family support for increased physical activity can elicit positive results. Technology these days can be used to track exercise or to calculate or reduce the calorie intake of foods, plan meals, or stay in touch with diet and exercise counselors. An improved understanding of fat redistribution and accumulation is needed, and research in this orientation needs to be done for developing more potent therapies of obesity. And considering the history of other metabolic diseases like hypertension, dyslipidemia, and diabetes, it should be observed whether the ongoing trials of anti-obesity agents provide evidence that they can improve MACE. So the ultimate aim is to chisel about the extra fat in the body and to stay in shape. However, for those who couldn't, there is a tribe in Ethiopia where men with the highest belly, the biggest, largest bellies are the more adorable. So we can always give solace to people with high BMI that you are not fat, you are just born in the wrong tribe. Thank you.
Thank you, Dr. Saihwal Goa, for your masterly presentation. I'll give only two comments. The first is, take care of the patient's economical and social status and try to give him instruction about the local food. And second is, take care of yours also. If you will be fit, the patient will be fit. If you are not fit, the patient will give a sarcastic comment outside that he is not fit और हमको सिखा रहे हैं कि ठीक रहिए. So this is also significant. So any question, please?
Mike.
Thank you. Very nice presentation.
Thank you, sir.
At one point you said quality is more important than quantity.
Sir,
I beg to differ. Somebody is very fond of taking...
Sir, not audible, sir.
Yes. Somebody is very fond of taking mutton and you said don't take mutton. You can have 75 to 100 grams twice in a week. I'm just telling a story. One of my patients fell everywhere. Then I went into analyzing his diet. So how much milk you consume? He said, आप तो मना नहीं किया है. अब हम लोग राजपूत हैं और जर्सी गाय है तो 9 लीटर दूध आता है तो 6 लीटर का छना बना देती है वही पर हम खा जाते हैं. So quantity is very important and never stop target any particular item in a diet. That is the first the person will resist you. साला हमारा सब खाना बंद कर दिया. So both matters. In moderation everything should be allowed.
Right, sir.
Just two comments, Dr. Sheval. There's a wonderful talk. You have covered almost everything. One is that BMI today has got a lot of limitations. So the Association of Obesity Americans and all that societies have decided that because BMI should not be the only criteria for obesity, waist-hip ratio, or waist circumference and waist to height ratio should be added in the parameters when you're talking about obesity.
Yes.
That is one point. Number two, you talked about certain fat diets, like the SNAP diet. I don't know what the SNAP diet means for you, but for me, SNAP diet is the best diet. Why it is the best diet? Because what I call SNAP diet is different. And that's an acronym for SNAP, SNAP, which stands for the diet should be sustainable, it should be nutritious, it should be affordable, and it should be palatable. So if you have these four features, then only the person is going to stick to that diet. Otherwise, he will never stick to that diet.
Your acronym is the practical acronym. This is the internet SNAP.
Dr. Guha, excellent talk.
Thank you, sir.
I just wanted to know, we see a lot of patients who has got obesity running in the family.
Right, sir.
बच्चे भी है, mother भी है, सभी. तो is there any correlation of obesity with the genetics?
Yes, sir. I showed that in my slides that the monogenic obesity, there is a 40 to 70% of inheritance.
Dr. Guha, the answer to his question should be obesity runs in the family, but he does not run.
Thank you.
Thank you.
Thank you, Doctor
Thank you, sir.
Guha.
Dada,
Next
एक
presentation
question.
will be by Dr.
Actually, Edmonton classification is also incorporated in WHO's that BMI, and there are three other classes which classify people for the treatment. They are all incorporated in WHO's that BMI classification system. So, how can we accurately address the patients according to the class in which they fall?
WHO has basically till now devised the classification based on BMI, but as Vinay sir has said, the recent the height weight the ratio and the waist hip ratio has been taken into account, but it still doesn't classify treatment as per the
Actually,
level.
what I do, I classify patients according to BMI plus Edmonton, and there are some studies from CMC Vellore. They also classify patients for the treatment. So that almost accurately classifies patients in the treatment class.
Okay.
How should they be tackled as per their obesity? So is there any guideline or anything
No,
else?
as far as WHO is concerned, the only guideline in treatment based on BMI is for bariatric surgery.
Okay. Okay. Thank you.
Okay, thank you. Now my colleague, please.
Thank you, sir.
So after an excellent and absorbing presentation by Dr. Saibal Guha, we are ready to hear from one of the stalwarts of endocrinology as from Rajasthan, Dr. S.K. Sharma. Andropause, a myth or a reality? Definitely a topic which will interest many of the persons sitting on the front bench. जिंदगी में हम लोग सब कोई अपने आप को मर्द जो है वो एक बड़ा जबरदस्त वाला कॉइनेज हम अपने आप को समझते हैं, बट एक्चुअली आर वी और डू वी सीज टू आफ्टर सम टाइम? सर विल क्लियर इन द बेस्ट पॉसिबल वे. ऑल द बेस्ट सर.
थैंक यू. सो आपकी बात पे मेरे को याद आ गया कि जब हम 10-15 साल के थे तो 30 साल वाले आदमी को कहते थे एक बूढ़ा आदमी आया है घर पे. जब हम 30 साल के हुए तो हम कहने लगे 50 वाले को कि थोड़ा बूढ़ा है. पर अब हम जब 60 के हो गए हैं तो हम 80 वाले को कहते हैं कि वो बूढ़ा है. So dear friends, I am thankful to Dr. Virmani for inviting me here in this beautiful city. And can you change my slides? Yeah. So as the title of this talk is that andropause, reality or a myth. Really it is a appropriate title because there are so many different things happening here in the field of andropause as we are increasing in our age, and many times we think that everybody is having development of andropause just like menopause in ladies. But we male are different, and I will be discussing this aspect, that how and why we are having this debate of myth and reality. So andropause is a Latin word where it means that human male with pause of his maleness, or male climacteric, or you have late onset hypogonadism. So dear friends, there are various, you can say, ill-defined terminologies for this, this condition. Most of the time we say that it is a andropause or ADAM, that is androgen deficiency in aging male, and sometimes we say menopause, that is just equivalent to menopause. But we are having no menopause, there is no immediate, or you can say clear-cut differentiation between the development of menopause, just like in ladies, in men. So we have gradually declining level of androgens, and you can see here, things starts developing after 30 years. So you find as the age is increasing, whether you take testosterone or free testosterone index, they are having more and more chances of developing these deficiencies. And here you find that with the age, there is a decrease in testosterone, and there is an increase in sex hormone binding globulin. And we all know that free testosterone is present only in 2% in our system. Rest is bound to proteins, or you find that there are sex hormone binding globulin and albumin. So you have gradually declining testosterone in our male patients as the age is increasing. This is very gradual, and smaller, and clinical consequences of this decreasing androgen is not yet fully, you can say, enumerated. Serum testosterone exhibits a diurnal variation, and that's why we had to measure testosterone level only in the morning hours, 7 to 10, 11, something like that. European male aging studies have clearly told us that there is a continuous declining testosterone when the age is increasing, like 0.4% per year of total testosterone, and when you look into free testosterone, there is a 1.3% decrease in free testosterone every year. Sex hormone binding globulin, we just discussed, it increases with age, and in this other study of Massachusetts male aging study, they say that every year 3% of our male hormone is decreased. So how come these things are happening in a elderly male? First is the testicular functions are decreasing with the age. There is a decrease in testicular volume, decrease in number of Leydig cells, decrease in the testosterone secretion synthesis. We have also neuroendocrine problem, like there is a decrease in GnRH pulsatility, and that lead to decrease in LH signaling, and LH signaling is also having less effect at the level of the testicles, and of course SHBG is increasing and free testosterone is decreasing. So dear friends, if you see here, men over the age of 50 years are having continuously decreasing androgen concentration. If you look at prevalence, it is again broad, you can say, figures there. 3.1 to 7% of the men with age between 30 to 69, and 18.4% male who are having age more than 70 years. And if you say symptomatic androgen deficiency, it is something like 5.6% in younger, and something like higher as the age increases. So you have so many symptoms of andropause. But if you look clearly, you find so many of them are so vague. So usually we take the symptoms like decrease in libido, desire, okay, and decrease in your morning tremulosity of penis, or decrease in morning erection, and decrease in the sexual performance. But there are so many other things: decreasing strength, energy, stamina, irritability, etc., sleep disturbances, depression, and change in cognitive functions. And you find there are some other symptoms also and signs also, like osteoporosis, and muscle mass is decreasing. You have increase in visceral adiposity. You have more of gynecomastia in these patients, testicular atrophy and central obesity, and increasing insulin resistance. So dear friends, look at the physiology of a hormone like testosterone. We all know that there is two types of hypogonadism. One is primary, that is the defect is occurring at the level of the testicles. So testicles are not producing sufficient amount of testosterone. Thereby there is an increase in LH, FSH because of decrease in, you can say, our usual counter regulation. On the other hand, when the defect is at the hypothalamus or pituitary, you have less of LH and FSH, and it leads to decrease in testosterone from the testes. So these are primary and secondary type of hypogonadism. As the age is increasing, here they have given age of 25 and 85, you definitely see there is a gradually decreasing testosterone levels, and you find that most of these testosterones are bound to sex hormone binding globulin or to the albumin. And this albumin binding testosterone is a loosely bind. So you find that it is considered as a bioavailable testosterone. Okay, only 1 to 2% is free testosterone in our system, but there is a great diurnal variation in testosterone. So you find that in the morning hours, their levels are very high as compared to in the evening, but this change, this difference is gradually blunted out as the age of the person is increasing. So in the lower graph you can see that the changes are milder. In the morning they are slightly higher, but that great changes which was seen in a younger person is not seen here in a younger patient, in an older patient. So how testosterone acts? Testosterone acts by three ways. Either it is acting directly like in the muscles, or it is converted into dihydrotestosterone, which is more potent than the testosterone and acting at the prostate and skin, or it is converted in our adipose tissue into estrogen, and there it is acting at brain and bone level. So dear friends, site of testosterone action is multiple. You find most of our organs are having testosterone receptors, and there are effects, some good, some bad effects of these testosterone in our systems. So here you find how to diagnose this and evaluate this andropause. So you have these type of signs and symptoms what we discussed, then you look at biochemical confirmation, and then you see whether the patients are really responding to testosterone replacement therapy. So these are the signs and symptoms of androgen deficiency in our elderly males: decrease in libido, virility, sexual activity, etc. And you find that there are some validated questionnaires are also available. For example, one is Adams questionnaire. You can keep it in your outdoor and you can ask the patient to give answers to these, and you find here that the scores do not predict or correlate well with the measures free testosterone or total testosterone, and therefore lacks the specificity. Again, the picture is not very clear here that these patients who are showing Adams questionnaire positivity will have decrease in testosterone. So initial evaluation is always to rule out potential causes of low testosterone, like patient is having untreated sleep apnea, uncontrolled diabetes, hypertension, chronic diseases like renal, liver, or thyroid hypothyroidism, anemia or malnutrition, or acute illness. Never measure testosterone in acute illness because it will be low. Then look at, repeat the test. One test is not sufficient, you have to repeat it, because 30% time you will find whatever come earlier as a low may come normal in 30% of our patients. And then of course rule out these testing, and if you are having some suspicion, you find that probably you are dealing with secondary hypogonadism, look at LH, FSH, and look at prolactin and iron studies, etc., and hypothyroidism, etc. So variability of testosterone is there. You find that 30% of our male are having low testosterone on one test and normal on other. 15% of the healthy male may have sometime lower level of testosterone. They are healthy persons. And then you find there is so much of variability here in measurements of testosterone. So you have to repeat the test, and when you repeat it and you have signs and symptoms, look at morning testosterone. If it is normal, okay. Otherwise, you look at LH, FSH, and some of these SHBG, etc. And if they are low, then you have secondary hypogonadism. If they are high, then it is primary hypogonadism. So how about a low normal testosterone? If you have a patient comes to you with 300 testosterone nanogram per liter, then you have to draw a AM sample again, repeat it, and then exclude acute illnesses, exclude all those chronic illnesses what we just enumerated. And then of course, if you have patients who are still having hypogonadal symptoms, then you go for testosterone therapy. But before that, you have to be very careful that you measure either free testosterone or bioavailable testosterone. And once you say that I will start therapy, give it therapy for 3 months or so and reanalyze whether that therapy is also helping the patient or not. If not, then you discontinue. So there are so many associations of testosterone level with outcome in older men, particularly as we say that there is a positive association with muscle mass, muscle strength, self-reported performance of physical function, sexual desire, and bone and mineral activity. There was a landmark study by the name of T trial, and here basically it is a trial where are 7 trials combined together, and they looked into male who are having more than 65 years of age and their testosterone level was less than 275, and when they analyzed, they found out that the sexual function with testosterone therapy improves, physical function improves, but vitality is not improved with testosterone, and anemia definitely improves. Anemia of unknown cause is definitely showing improvement. Cognitive functions are not improving with testosterone therapy. Bone trials are showing some improvement in bone mass, and then of course cardiovascular trials are telling us that there may be increase in atheroma burden. So is andropause a myth or a reality? So I will discuss this slide at length. You find that picture is so muddy here that it is a insidious, slowly progressive decline in testosterone, and testosterone levels are definitely decreasing with age. But whether it is a normal physiological changes or it is pathological is to be looked into, and there are so much disagreement on how to define andropause, whether symptoms are there or not. Symptoms are so non-specific, and of course testosterone threshold at which symptoms manifest, they are subject variability, and you find low testosterone studies are taking different cutoffs. Some is saying below 300, 275, 150. So all those studies are taking different cutoffs. So we are not really sure what should be the level below which we say that this level is low. Nowadays, general consensus is if the levels are less than 230 nanogram, then patient may need treatment if symptoms are there. If it is more than 350, then probably you hold and look at other causes like anemia, hypothyroidism, etc. And then of course you can decide, repeat the test. Variability of testosterone level we already highlighted. Then not all the elderly males are having low testosterone. There are elderly who are having normal testosterone. And on the other hand, there are young people, 15% of them, who are having lower levels of testosterone, but they are young, healthy people. And then of course there is a change in diurnal characteristics of these, and day-to-day variation is also occurring, and many elderly men have significant symptoms of testosterone deficiency, but when you measure them, it is normal. So things are not really very, very clear. Elderly people with low testosterone did not show significant improvement when you start treating them with testosterone replacement therapy. So the things are so difficult, and you are having now people using them in large number. I should say misusing testosterone therapy in large number of patients, particularly those who are looking for bodybuilding, etc. So if you think that andropause is a reality, how to approach these patients? And here they say the testosterone treatment is not indicated in all elderly people with low testosterone level. You have to look at low level as well as symptomatology. And then, of course, severity of testosterone deficiency is to be looked into. What are the burdens of symptoms, and then increasing the patient's risk of harm because of testosterone is again very important thing. And you have to sit across the patient and advise him pros and cons of testosterone therapy. This is a beautiful slide in the latest Harrison. And what they highlighted is that an individualized patient-centric approach to share the treatment decision making in an older man with testosterone deficiency. There are 4 things here: severity of the testosterone deficiency, burden of the symptoms and likelihood of responding to testosterone replacement therapy, and conditions which are going to be increased, the risk is going to be increased in this patient, and weigh the burden with pros and cons, whether the therapy will be helpful to them or not. So with that, older men and with age-related decline in testosterone, you find that population screening is not required. So any male comes to you, don't measure testosterone. Only when he is having symptomatology, only then testing should be restricted to men who have symptoms or physical features. There is a lack of evidence of long-term safety and limited evidence of long-term efficacy of testosterone. An expert panel recommends, our endocrine society panel recommends, that the testosterone therapy should be offered to an individual basis, and mostly above 65 years of age, those who are having symptoms and associated with low testosterone level, and like low libido, unexplained anemia are consistently showing improvement. But there are so many contraindications to testosterone therapy, particularly breast or prostate cancer, lump or hardness of the prostate, PSA more than 3, severe untreated BPH, severe lower urinary tract symptoms, erythrocytosis and hyperviscosity, untreated obstructive sleep apnea, and severe heart failure. So testosterone for the following reason may be harmful: to improve the strength or athletic performance, for physical appearance, and to prevent aging. That is again important. So there are so many risks of testosterone therapy: fluid retention, gynecomastia, increased red blood cell, worsening of the sleep apnea, promotion of being benign or subclinical malignant prostate disease, or possible added risk of cardiovascular disease. So there are so many things available. I will just take 1 minute. There are some preparations like oral, intramuscular, and patches and gels which are available, and you have so many options for the treatment of testosterone deficiencies. There are now buccal bioadhesive testosterone pellets are also available. You can say these are the pellets which can be implanted, 3 or 4 pellets, which may be effective for a period of 3 months to 6 months or year. And then of course you have to look at the side effect profile, and you find that a patient on testosterone therapy developing significant gynecomastia, and here he says that I stopped taking drug because I am feeling better without drugs. So you have to monitor the therapy if the patient is on testosterone therapy. This is the last slide. They say that long-term health risk and benefit of testosterone are not established. A baseline physical examination is to be done. Within 3 months, evaluate the weight gain, peripheral edema, gynecomastia, tenderness, sleep disorders, and get a hemoglobin. You will find within 3 to 6 months, patient HbA1c level, hemoglobin level goes very high. So you have to be very careful. If the hematocrit is going above, you can say 50% or so, a rapid rise in PSA is also to be looked at. Measure the testosterone also, because you are giving testosterone, but if the patient is not achieving good testosterone level, something like in the lower panel of a healthy person, something like 400 of you can say nanogram of testosterone, then probably you have to intensify the therapy also, and then you have to look at the clinical response. If not responsible, if not giving good response, omit it. Sometime when you are giving testosterone for bone health, you have to measure BMD every 1 year or 2 years or so. So with that, the caveat remains, there is still to be used testosterone with all the carefulness. Thank you very much.
Thank you, sir, for a wonderful presentation. Touched every aspect of the estimation of and the clinical judgment, where to use it, What are the side effects? Well touched everything from your side. At least at my level, I can understand that still now there is much to look after before we jump into a suggestion, or the consensus is yet to be built up regarding whom to screen and when to screen and what will be the therapy.
Yeah.
But yes, the monitoring needs to be very, very stringent, and the follow-up.
Absolutely.
Otherwise, we lose more than we gain.
Absolutely.
And definitely, my perspective, the social aspect which I say, whenever you screen a patient for a testosterone deficiency, unless there is a very remarkable indication to do that, in our socio-economic responsibility, no sir, the status in which we Indians are living, we don't believe in polygamy till now, even though many have that hidden interest, but we don't believe in that. So I don't think much of is still now to be recommended as far as testosterone testing and intervention is concerned. This is my take on this issue. The house is open for the questions, sir.
Excellent talk, Dr. Sharma.
Sir.
I just have one query. Normally we do serum testosterone. When should we go for free testosterone?
Well, whenever you are having problem, like you think that SHBG, sex hormone binding globulin, are interfering, means, for example, patient is on hypothyroid treatment or hyperthyroid treatment, or advancing age, or obesity and insulin resistance, hyperinsulinemia, or some other medical therapies. These are influencing the binding of this testosterone. So it is easier to measure total testosterone than free testosterone. So free testosterone requires really difficult measurement. LMLC methods are there, which is very, very costly and not available everywhere. But what they identified is that free testosterone index, which is total testosterone divided by sex hormone binding globulin and into 100. So this is an index which tells you indirectly that what is the bioavailable testosterone which is available to the person.
Excellent talk, Dr. Sharma, as usual.
Thank you, sir.
My question is that do you have any role of melatonin in testosterone secretion and lack of sleep? Because there is early rise of testosterone level and melatonin increases in the evening time.
Well,
so does any role of
absolutely. Many of our hormones are maximally secreted in the late night, and we require a good sleep for that. And you find that most of that hormones, whether you talk of corticosteroids or testosterone, etc., they are higher in the morning hours. So a good sleep is definitely required, because a impaired sleep will have neurocognitive dysfunctions as well as endocrine disorders, which may influence the level of testosterone. You are absolutely right. And similarly, we see that if the patient is having obstructive sleep apnea, first correct it rather than jump to testosterone therapy. Because once you correct obstructive sleep apnea, testosterone level improves. Once you correct obesity, testosterone level improves.
Sir, I just wanted to know, when we advise for testosterone test to a patient, when should be the best time to give sample?
Yeah, absolutely right. This is a very important question, because as we discussed, there is a circadian rhythm of testosterone, and the maximum testosterone levels are in the morning hours. So they say 7 to 11 is the ideal time for taking a sample of testosterone. And never rely on one. If it is abnormal, please repeat it and then decide, because as we discussed, 30% time low level may come normal in the next test.
Thank you for a masterly talk. I have a comment, not on your talk, sir.
Sir, I'm not able to hear you.
Hello?
Yes.
I think it will not be an exaggeration if I say physicians, I mean physicians, not the cardiologists and neurologists and others, are treating more patients of benign prostatic hypertrophy than the urologist. It will not be an exaggeration. We are treating many more benign prostatic hypertrophy. And we use dutasteride. And I have seen many cases, because as you said rightly that dutasteride,
Testosterone.
Testosterone active form, that's what dutasteride prevents conversion of testosterone to dihydrotestosterone, and it causes severe sarcopenia and the other physical symptoms you have. I have noticed in so many patients. I asked one noted nephrologist who did my prostate surgery in 40s also. She said, yes, this is very much there, not much in literature. But I warn my colleagues, if your patient complains, jila ho raha hai, kamjori lag raha hai, and he is on dutasteride for a long time, please stop it and see if something more could be done. This is
Absolutely. I agree with you, sir. Thank you.
Sir, just I would like to know one thing. Is there any place of phosphodiesterase inhibitor? Phosphodiesterase.
Phosphodiesterase inhibitors.
Yeah.
So we are using these phosphodiesterase inhibitors, 5 phosphodiesterase inhibitors for the erectile dysfunction. So many times what happens, our diabetic patient, for example, you are giving good amount, like not 50 but 100 milligram of Viagra, and still response is poor. Then look at that hypogonadal part of that patient also. Because many of these patients show good response to this 5' dehydrogenase inhibitor if you are having a background of treatment of hypogonadism. So if not responding, please look at the testosterone level of that person.
Thank you, Dr. Salman. Last comment is, while I was working in Tata Main Hospital, I was consultant of Tata Football Academy. There was a coach, Mr. Banerjee. He was very strong physically. He used to say only this line, more is the physical fitness, more is the sexual fitness. So he was very much troubled by the player who were going to outside for playing. Thank you.
Thank you, Khan sir. And after that, Khan sir started walking daily in Jubilee Park to stay fit. Okay, thank you so much. Again, loud round of applause for both the speakers. A very good morning to all those who have joined us late. May I request the chairpersons to please hand over the memento to both the speakers. Dr. Guha sir, please. Dr. Umesh Khan sir, to please present to, okay. So both can decide. Dr. Umesh Khan sir to Dr. Sharma. Dr. Jaiswal to Dr. Guha. Good. I would request, please wait. I would request the speakers to please hand over the mementos to our chairpersons. Dr. Sharma to hand over to Dr. Umesh Khan. And Dr. Guha to hand over to Dr. Jaiswal. Thank you so much. Okay, moving ahead to the next session, for which we know we all are waiting for it, the debate of this morning, and a very appropriate topic, vitamin D is overhyped. May I request the moderator of this debate, Dr. Puneet Saxena, to please come on the dais. We have got two speakers, Dr. Amit Das from Muzaffarpur and Dr. Satish Prasad. Topic is vitamin D is overhyped. Dr. Amit is going to speak in favor. Both the speakers are requested to come on the dais.
Once more, I'd like to tell the rules of the debate for those who have come in new. Each speaker is allowed total of 15 minutes. There will be a warning bell at 13 minutes. At end of the both speakers, both will be given 2 minutes for rebuttal. And in the end, the moderator will sum up in 1 or 2 lines. Please start.
So, good morning everybody, and at the very outset I thank the Japicon team, especially the Jamshedpur people, Dr. Ram Kumar and Dr. Anil Vermani, to have me here and given me this opportunity to visit this beautiful place. And without wasting any time, we start with the debate on vitamin D, the most pertinent problem, the most drug which is having a perennial prescription, and the question looms large whether it should be prescribed to all or it should not be. So for the motion, Dr. Amit Das will be speaking that whether it's overhyped, and against it will be Dr. Satish from Jamshedpur. So first I invite Dr. Amit Das to speak in favor of the motion.
Hello. Thank you. My बाप प्रणाम. Moderators have. Sir, right theme selected and right topic given. Thank you, Virmani sir. When a thing ceases to be a subject of controversy, it ceases to be a subject of interest. My talk is in favor of a drug which has been overhyped, that is vitamin D, and this is what I am, and I don't have any disclosures for this topic. On a personal note, I have so many disclosures. A huge respect to Dr. Virmani and his scientific team. Lots of love and fondlings to my friend Dr. Ram, and belongingness to this place, which is Jamshedpur. Thank you for inviting me for this topic. This is D, which is in your mind. But to me, vitamin D is this. On a scientific note, it's a fat-soluble vitamin. Vitamin D2, vitamin D3, 90% being absorbed through the skin, taking the help of liver and kidneys to an active metabolite which acts at the VDR receptors, activating the RXR genes and causing lots of actions. VDR is present almost in all cells of the body and has so many effects. What if VDR is not present? This is the KO mice experiments, which is the knockout experiments. So knockout experiments on mice, if you just knock out the VDR gene, what happened to these mice? So the mammary glands in those KO mice were more prone to breast cancers, cardiac muscles developed cardiac hypertrophy, liver became fatty, the prostate became hyperplastic, the atherosclerosis accelerated, the mice became resistant to diet-induced obesity. And VDR activation will lead to so many things. These are the pathophysiological things, and it seems that vitamin D is a superhero. It acts as almost everywhere. My friend, my senior colleague, Dr. Satish, might be very happy to see these slides. So it's an omnipotent. So I think vitamin D or Rajnikant. So is vitamin D the Rajnikant? Lots and lots of papers favoring vitamin D has been present on the research papers, and so many pathophysiological explanations have shown, are trying to show that vitamin D is the superhero of all pathophysiology. It will cause advantage to your heart, it will cause advantage to your diabetes, it will cause advantage to your autoimmunity, it will prevent infections. And what it had an impact? It had an impact on the market. The growth rate of vitamin D sale has gone like anything. And I think Dr. Satish sir is playing in the hands of the market. So he's going to promote vitamin D. So the CAGR is almost 7%, which is a good number. Almost 600 million US dollar is the market of vitamin D. Are we playing in the hands of the pharmaceutical industries? Do we have any scientific evidence strongly favoring vitamin D? Consensus is vitamin D is good for nutritional rickets. Number one. Consensus 2, vitamin D is the 25-hydroxyvitamin D is the best marker of vitamin D status, and consensus 3 is definition or thresholds of vitamin D have been more or less acceptable across the world. Sir is so happy. अब खुशी के आंसू रुक नहीं रहे हैं. मेरा opponent जो है मेरे ही favor में बोला जा रहा है. This is what vitamin D is. F means 3 arrows one time and multiple arrows to the enemy, and the diseases have gone flat. But what is actually happening is all the targets are missing. There have been lots and lots of controversies in vitamin D, hundreds of papers. The latest papers of 2023 also shows that 100 years of discovery, yet controversies continue. So vitamin D is equal to C, which vitamin D is equal to controversies. So vitamin D, by the name, vitamin is not a vitamin actually. So the name itself is a controversy. What are the scientific evidences? So I can tell you hundreds of causes of controversies in vitamin D, but the time will not permit me to do that. So I'll focus on few scientific evidences. These slides, I'm sure Dr. Satish must be showing this, and I'm sure you must be knowing that there are so many causes of vitamin D deficiency, and if you label so many causes multiple, possibly you are not actually knowing what is the cause of vitamin D deficiency in India. Do you know what is the prevalence of vitamin D in India? Almost 70 to 100%. So almost all of us are vitamin D deficient. So which means we should all have diabetes, we should all have hypertension, we should all have tuberculosis, we should all have respiratory disease, we should all die in 10 years. So there have been controversies in the doses of vitamin D as well, and there have been controversies in the cutaneous absorption of vitamin D through the ultraviolet bullets. Let's examine these evidences. In some 10 large prospective placebo-controlled studies of approximately 57,000 patients who were followed for 5 years, two parts of the studies I'll try to explain. One is a large single dose of almost 3 lakhs intramuscular injections or oral of 5 lakhs. There was an increased risk of fractures. So vitamin D, if you give in large dose, it will cause fractures. And if you give intramuscular injections of vitamin D, it will cause increased falls. So vitamin D is a bone vitamin, but actually if you give it in large doses, it will cause more fractures, more falls. What about the cardiovascular studies? This was a study which is the vitamin D assessment study, and it was a randomized clinical trial. Almost 5,000 people were involved in this study, and this did not show that vitamin D supplementation in the dose which was prescribed, which was 2 lakh per month, and frequency did not prevent cardiovascular disease. So this was one study, and there have been multiple studies, meta-analysis, which have failed to prove that vitamin D supplementation is going to have a cardiovascular advantage. Vital study, which is the most meticulously planned randomized clinical trial, have also failed to show that supplementation with either the omega-3 fatty acids at a dose of 1 gram per day or vitamin D3 at a dose of 2,000 international units per day was not effective for primary prevention of cardiovascular or cancer events. With Vital 3 had so many arms, which was a Vital Rhythm trial, it also didn't show that the vitamin D supplementation is going to prevent atrial fibrillation. There's another arm to this, which is the Vital CKD, and Vital CKD didn't prove that adding vitamin D to your patients prevented CKD progression. So vitamin D possibly is a placebo. What about diabetes? Most of you must be interested, and this is the New England Journal published in 2019, which was the D2D study, and this was randomly assigned adults who met at least 2 or 3 glycemic criteria for pre-diabetes and no diagnostic. So these were pre-diabetic patients, and they were supplemented with vitamin D. And what did vitamin D do? Did vitamin D prevent these pre-diabetic patients to go into diabetes? No. Among persons at high risk for type 2 diabetes, not selected for vitamin D insufficiency, vitamin D3 supplementation at a dose of 4,000 international units per day did not result in a significantly lower risk of diabetes than placebo. So vitamin D is not going to prevent progression of pre-diabetics to diabetics. This was the diagrammatic representation of the D2D study. Other studies have also shown that, but just on a smaller note, if the baseline vitamin D of individuals were low, which is less than 12 nanogram per ml, so supplementing those individuals with very low vitamin D could prevent 62% reduction in going into diabetes mellitus. So in only those subgroup of populations who were severely vitamin D deficient, these had the potential of preventing. Other trial, which was the DPV trial, also failed to show that this vitamin D is going to have a preventive effect in the incidence of type 2 diabetes, nor a beneficial effect on the rate of regression to normoglycemia. As far as cancer is concerned, the trials have also shown that supplementation with vitamin D did not result in a lower incidence of invasive cancer or cardiovascular events than placebo. Meta-analysis have also again proved the same thing. So you use multiple trials and you analyze them, and at multiple analysis also there has been no noticeable effect of vitamin D in preventing cancer in any of these studies, though the vitamin D level in these individuals were high enough. So this is in nutshell various trials which have large vitamin D supplementation clinical trials, and none of them have shown that it is going to be an advantage. Asthma, even in Dr. D.P. Singh sir is there, and for his kind notice that asthma vitamin D does not prevent attacks even in individuals who are adults or children. So vitamin D doesn't have any effect. In acute illness, even the assessment of vitamin D in acute illness is faulty. So don't go for a vitamin D assessment in your ICU patients because of the various physiological changes in the acute illness. Vitamin D requirements during reproduction doesn't have much effect on the fetal and neonatal health. So supplementing vitamin D in your normally healthy pregnant ladies doesn't have any impact on the reproduction. In tuberculosis also, it doesn't show any significant difference in positive tuberculosis test between the groups. It's 3.6% in vitamin D group versus 3.3 in the placebo group. So vitamin D is not going to prevent tuberculosis. It doesn't seem to. So finally, let me tell you one thing, that vitamin D is a threshold value nutrient, which means that at a physiological endpoint, such as the calcium absorption, is enhanced in dose response fashion up to a threshold value, above which higher dose doesn't go on to give you a greater benefit. So once you have achieved the vitamin D therapeutic level, it doesn't give you any significant or any advantage. So the only point for you is to achieve a normal value of vitamin D, and beyond which supplementing vitamin D is useless. तेरे वादे पर जिए हम तो ये जान छूट जाना कि खुशी से मर न जाते अगर एतबार होता. Thank you, sir. So you must have received this melody right now. Melody खाओ, खुद जान जाओ. Thank you very much.
Thank you, Dr. Amit. And now I invite Dr. Satish, and then we will have a discussion and rebuttals after that.
It's not changing there. So good morning, ladies and gentlemen. Before I start, I would strongly condemn the statement given by my opponent that I am sold at the hands of pharmaceutical companies. Let me tell you, my friend, this topic was given to me by the Scientific Committee of Japicon 2023. I have brought in E-Suraj, E-Sun on this screen, you can see, because the organizing committee has deprived the audience from vitamin D for the last 2 days. And I can see the happiness on my opponent's face that he is quite convinced that he is not going to develop melanoma. Let me put in front of you some very interesting but very alarming data. As 1 billion people worldwide are vitamin D deficient. 50% of the population has vitamin D insufficiency. And obese subjects are more prone to develop vitamin D to the tune of 35% more than normal people. Middle East countries, where the skin is covered mostly, they have high prevalence of vitamin D deficiency. 90% of infants in Iran, Turkey and India, they are vitamin D deficient. As far as elderly population is concerned, 61% in US, 90% in Turkey, 96% in India, and 72% in Pakistan, 67% in Iran are vitamin D deficient. And let me put a very recent data published in Times of India, 30th January 2023. 3 out of 4 Indians suffer from vitamin D deficiency. And young adults less than 25 years are more affected. This shocking data came from Tata 1mg labs that revealed that 76% of Indian population suffer from vitamin D deficiency. And this survey was done over 22 lakh people spread over 27 cities in India. 79% of male and 75% females were vitamin D deficient. Vadodara and Surat, with the values of 89% and 88% were the highest, and the Delhi NCR was the lowest with 72%. The prevalence was highest in the age group of less than 25, 84%, followed by 25 to 40 years, 81%. And Dr. Rajiv Sharma, Vice President, Medical Affairs, Tata 1mg, opined that changing food habits, indoor lifestyle, we are turning sun-shy rather than sun-loving, low consumption of fortified cereals and oily fishes, and seasonal variations are the cause. Unspaced and unplanned pregnancies in women with dietary deficits leads to vitamin D deficiency in both mother and child. And we all know that when a lady is pregnant and deprived of adequate vitamin D, there are chances of preterm labor, there are chances of she going into cesarean section, and even the birth of the fetus, death of the fetus. And out of these fat-soluble vitamins, vitamin D is the most important. My opponent also agreed to it, and he showed a lot of data for it. And we all know that vitamin is a vital amine, essential for health. It's an organic compound, not made at all or not made in sufficient amounts by the body. So what is it? It's a fat-soluble vitamin, but it acts more like a hormone than a vitamin. So it is also called sunshine hormone. It's a neurosteroid, endogenous, synthesized from cholesterol, and regulates a number of genes. Exists in 2 forms, D2 and D3, and it has got endocrine, paracrine, and autocrine functions. This is the synthesis of vitamin D inside the human body, as shown by my opponent also. So I will skip this slide, only saying that vitamin D2 and vitamin D3, they are inert and they become active after the 2 steps of hydroxylation, one in the liver and then in the kidney. And then the calcitriol is the form which is the active form of vitamin D available in the human body. And this is the bioadaptation to the vitamin D deficiency. Reduced vitamin D will lead to reduced intestinal calcium absorption, leading to hypocalcemia, and then secondary hyperparathyroidism as a compensatory mechanism, leading to increased calcium release and decreased renal calcium clearance, and this is how the normalization of serum calcium is maintained. The cutoff values has been agreed by most of the international bodies, sufficient when the vitamin D level is 25-hydroxy vitamin D level is 30 nanogram per ml and above, insufficient between 20 and less than 30, deficiency less than 20, and it is called severely deficient if the value is less than 5. And the dose of supplementation has been almost agreed by many bodies, 18 to 50, 200 international unit per day, 15 to 70, 400, more than 70, 800 to 1000. But if the exposure to sun is inadequate and in a high risk population, the supplementation should go up to 800 to 1000 international unit per day. At risk of vitamin D deficiency, lower circulating vitamin D in inadequate sun exposure in chronically ill patients, institutionalized or homebound, and those who have got poor dietary intake, more than 50 years of age, obesity with a body mass index of more than 30, because body fat sequesters vitamin D, and those who put on sun protective clothing and sunblock, the sun protective factor of 30. And this is depicts the causes and the consequences of vitamin D deficiency. On the left hand side you can see the causes. Many drugs which also can cause defective synthesis of vitamin D. Those are the glucocorticoids, rifampicin, the anti-seizure medications like phenobarb and carbamazepine. And you can see from tip to toe there is a list of diseases being mentioned, starting from schizophrenia, depression, up to rickets, multiple sclerosis, and the growth of cancers like breast, colon, and prostate, and pancreas also getting affected with vitamin D deficiency. The functions of vitamin D, as you all agree, improves heart function, enhances brain development, strengthens the immune system, provides advanced anti-cancer effects, strengthens muscle function, and essential for strong bones and teeth. And these are the symptoms of vitamin D deficiency, which can happen more in females, is mood swing because of the low estrogen due to vitamin D deficiency, high blood pressure, excessive sweating, digestive problem, dry skin, joint pain, immune impairment, and fatigue. And these are the sources, apart from the sunlight, which is the richest source: cod liver oil, salmon, sardines, sun-dried mushrooms, egg yolk. They are all good source of vitamin D. And you all know the importance of ultraviolet B rays, which can penetrate up to the dermis and leads to the synthesis of vitamin D from 7-hydroxycholesterol present in the human body. But danger is with the ultraviolet A rays, which can penetrate up to the dermis and can give rise to malignancies like squamous cell carcinoma and melanoma after long exposure. But ultraviolet B rays not always can produce melanoma, but there are reports that after long exposure it can happen. So moderation, sun exposure in moderation is allowed because it will give good amount of vitamin D to the body. Recent publicity on melanoma has reduced our sun exposure, so we are getting less vitamin D. And the known fact is that people with darker skin, such as African Americans or Hispanics, have much lower vitamin D levels than those with lighter skin. Elderly have thinner skin, and they have 25% less amount of this 7-dehydrocholesterol is left, and so the vitamin D synthesis is lesser in elderly people. And this is the study of hypovitaminosis D, a global perspective. Middle Eastern Africa registered the highest rates of hypovitaminosis D worldwide. Turkish, Moroccan, and Indian sub-Saharan African immigrants in Europe have higher level of hypovitaminosis D compared to the indigenous European population. And this is the state of affair in the United States of America. You can see the states on the northern part, that is the ultraviolet energy is insufficient for cutaneous vitamin D synthesis from November through February. But if you see the other side of the United States, states like Los Angeles, Dallas, Miami, and they have ultraviolet energy insufficient for cutaneous vitamin D synthesis year long. So the place, the geography is also very important. Another Euronet Seneca study which was done for the elderly persons, 16 European scientists participated into it, and the lowest value were found in Greece, Spain, in Italy. And way back in 1978, Lancet published an article saying that vitamin D deficiency does not exist in India. But there many studies were carried out from 2000 to 2006, and the outcome was 80% of Indians have suboptimal serum 25-hydroxy vitamin D. An Indian endocrinologist warned of vitamin D deficiency. Dr. Ambrish Mittal from Apollo Hospital, New Delhi, president of ISBMR, he says over 40% of healthy people surveyed in our studies have poor vitamin D, and this was published in BMJ 2003 journal. In 17th century, these gentlemen, Daniel Whistler and Francis Gleason in England, they discovered rickets, but there were reappearance of rickets in recent decades due to multiple factors. And I would say that there was a data that in central Tibet, 30% of children, they are still developing rickets every year. And you all are aware of the clinical features of rickets. And this is the importance of sun exposure. The further you are from the equator, the more chances of developing many diseases. And one example is multiple sclerosis. Another is several cancers. And there was a study, and these, let me tell my opponent, these are not studies done on pigs. They are Homo sapiens sapiens, all human beings. Breast cancer risk is less in people who go out in sun, and this study was done in Stanford University, studied of 1,700 women with breast cancer and 2,000 controls. They measured pigments on the forehead, and white women with high sun exposure had 47% less breast cancer compared to those with low exposure. Genes don't want to be making protein continuously. They need to be turned on and off through regulators, and vitamin D is a major regulator in humans. There are over 230 vitamin D receptors in the nucleus of most tissues in our body. And vitamin D also tells cells when to divide, stop, and divide, also when to die, that is apoptosis. Vitamin D is essential for our human system. The T killer cells who has got vitamin D receptors on them, they convert into killer cells and multiply also. And without vitamin D, the white cells are dormant. You know the role of vitamin D in psoriasis. Calcitriol is a potent inhibitor of keratinocyte proliferation. And the role in Parkinson's. Depression is 11 times as common in those with low vitamin D levels. There was a study done in Finland because the sun, even in the midsummer, the ultraviolet rays are not available for the synthesis of vitamin D, and the children, they suffer from diabetes. What happened, their government reduced the RDA, that is daily allowances of vitamin D. In 1960, it was 4,500, and it was reduced to only 400 international unit by the year 1992, and see what happened. The incidence of type 1 diabetes, which was only 17% in 1965, went up to 65% by the year 2005. Dr. Anthony Fauci, US top infectious disease doctor, embraced the idea of using vitamin D to help keep COVID-19 at bay, saying in September 2021 that he takes a supplement of vitamin D to avoid being deficient and would not mind recommending it to others. In COVID-19 pandemic, the vitamin D deficiency was found to be associated with high inflammatory markers. Let me quote from Times of India. The excerpt was, it is a disease of modern civilization. We have developed to working from dawn to dusk in air-conditioned office, only to immerse and plunge into
Dr.
indoor
Satish, your time is up.
Yes, just finish the last slide. During the rare sunshine exposures, either the maze of smoggy clouds or sun screens and protective clothing starve the body of supply. From busy executives to pushed students, mal-soliciting housewives, and even courting lawyers and in-clinic doctors, no one sees the light of the day, and vitamin D deficiency is rampant. Our opinion of the common man, Ruchika Rao from Thane, Mumbai, she says, this is bound to happen. Homework is so much, the women have no time to get out of the house. Many women keep on fasting to please their religious leaders. For a woman living in slums and clusters of high rise, sunlight is a precious commodity. Being conscious of white skin and fear of pigmentation, they do away from sunlight. So measures are recommended for So there is no doubt the most important vitamin we can take is vitamin D, and I request the audience not to get away with the misleading data and concepts given by my opponent. And I think I could convince the audience that vitamin D deficiency is not a hype, it is a fact, and science basically is dealt on facts and not on the basis of fictions which was shown by my opponent. Thank you very much.
So thank you very much, and we have heard both the viewpoints, and I now invite both the speakers on the dais, and I give the 2 minutes time to Dr. Amit to define what Dr. Satish has said.
Thank you, sir. I first of all apologize my senior colleague, Dr. S.K. Prasad, sir, for labeling him as an agent of pharmaceutical industry. I wholeheartedly apologize, but I want to know he is not in the hands of pharmaceutical industry, but he quotes the Tata 1 mg. So I think he is in the hands of the medical shops. Sorry, sir.
Tata,
sir, my time. 2, he quotes the problems of ladies. बहुत homework है, बाहर ही नहीं निकल पा रहे हैं. But he fails to give scientific evidences. Do we have scientific, real, hard evidence which tells you that vitamin D supplementation is going to prevent diabetes? He fails to give you any hard evidence that vitamin D is going to prevent cardiovascular deaths. He fails to give you any evidence that vitamin D prevents tuberculosis or for that matter any infection. He tells you stories of old men. He tells you his slide contains that vitamin D recommendations have fallen from 1964 to 2010 to 400 international units. And look what it has done. It has increased the incidence of diabetes in the world. So I find it absolutely unscientific correlating these two unrelated things on a scientific platform. I don't think we must buy his theory. My only submission is definitely supplement vitamin D in those severely vitamin D deficient, but do not get carried away by prescribing vitamin D to all those without testing. Do not get carried away. इसलिए कहता हूँ मेलोडी खाओ और खुद जान जाओ. Thank you, sir.
Thank you, Dr. Satish.
Yeah, thank you. I mean, thank you for first apologizing and then again alleging. And let me tell you that for your general knowledge improvement, Tata 1 mg is not a pharmaceutical company.
It's not a pharmaceutical company, it's the pharma shop, sir.
No, it's not a pharma shop. That is a lack of your general knowledge. You go and search the net. It's basically an organization, it's an institution which is based at Gurgaon, New Delhi.
And last night I went in front of TMH.
Yeah. So it is also giving people medicines at lesser rate, and it is also dealing with medical data and data analytics, and this is of great help. It was basically founded in 2015, and it is one of the ancillary companies of Tata's. So I think your basic knowledge about this Tata 1 mg is not correct. I showed many evidences, and this is for the House and for the judge to decide how many evidences I showed. And as far as the recent concept is concerned, let me tell you, the days of RCTs are over. Hear me. The days of RCTs are over. It is now we analyze the studies based on the Mendelian criteria and based on the Hills criteria, where the observational studies are given importance. So you cannot deny the importance of observational study, because the Mendelian criteria and the Hills criteria are now playing a greater role, which is based on several factors. I won't go into detail of that. So because you just can't go on the basis of randomized controlled trials. Of course, the meta-analysis out of the RCTs are very, very important. And let me tell you, in 2023, there is a Polish article published in the Poland Journal, which has studied and published the meta-analysis of several RCTs, and they all speak in favor of vitamin D deficiency, and not as a hype, but as a fact. And I won't give you the data right now.
So I think your time is up, and we have heard both these speakers, and it's true that vitamin D is a vitamin. It's needed for all, but in limited quantities. And with of late, we have been seeing that the sunshine diet and the supplements are the only source, and the deficiencies have been studied and it's prevalent highly. But my question, final question to both of you is vitamin D required for all? If yes, then for how much time and how much dose? And I think you both should have highlighted the toxicity of the vitamin D which has been used inadvertently. So the question is for both of you. Just a quick answer from both of you.
Sir, we all are, no, the surveys say that 70 to 100% of Indian population is vitamin D deficient. So going by the cutoff of 30 nanogram per ml, so we should take this as the guideline, and we try to supplement vitamin D to such a level that the vitamin D level goes to more than 30 nanogram per ml. So the recommendation is to supplement 400 international units per day to a dose which tries to achieve the serum vitamin D level to more than 30 nanogram per ml. One. If you go beyond 100 nanogram per ml, the side effect of vitamin D or vitamin D toxicity starts appearing, and it will cause hypercalcemia, hypercalciuria, and that will increase fractures and falls, which I showed in my first slide.
So, Dr. Satish, your take.
Yeah, the cheapest source of vitamin D is, of course, the sun exposure, and it is recommended.
Is it required by all? And if yes, then for how much time?
Of course. Whether you are white skinned or dark skinned, sun exposure is must, and those who are very fair, they have to get exposed to sun for at least 20 to 30 minutes with their forearm, the legs and the face exposed to sun. Other areas may be covered. So 14% of body surface should be exposed. And those who are dark, they should be exposed to the sun for a more longer period, say half an hour to 1 hour, because of the melanin coming in between.
So I want a specific answer from both of you. Is the supplementation required by all?
No. One word, no.
Now, I would say yes, and for this you have to assess the vitamin D level in
not for all.
So with that we come to an end, and both the speakers were partly right in their aspects, and debates are meant to keep the things in check and balances, and there cannot be a clear-cut verdict, and it's a worldwide controversy. So regarding the winner, I will leave it to the scientific chair, Dr. Vermani, that who has scored. So.
First of all, please give them a good hand. It was a wonderful debate. Both the speakers were excellent, moderator was excellent. Now, again, I take the privilege as Chairman Scientific Committee to give the final word. My premise is, should we call it deficiency? What do we mean by deficiency? Deficiency means when that substance is not present or less in the body and some harm is occurring. Like we have insulin deficiency, thyroxine deficiency. Even Ambrish Mittal, my dear friend, said that 50% of the healthy people have suboptimal levels. He didn't say deficiency. So first of all, I don't think there is anything called vitamin D deficiency except for bone health and when vitamin D levels are less than 30. As simple as that. Barring bone health, there is nothing called vitamin D deficiency. It is suboptimal levels. That is number one. Number two take-home message, whether we should treat all or not. If the patient, if you are looking at bone health, vitamin D deficiency, yes, treat, yes. If you are looking at other causes, normal vitamin levels, don't bother to treat. Person healthy and asymptomatic, suboptimal levels of vitamin D, please, it's a controversial gray area, but I will not treat and I will not recommend to treat because you will create unnecessary neurosis in the patient. So a person who is healthy, why you want to fix something which is not broken? As simple as that. Thank you.
Thank you, Dr. Vermani. And debates are kept to find an answer to those questions to which we don't have a definitive answer. So I think we are progressing towards that only. Thank you very much.
Thank you, sir. Very dynamic and interactive session and a real debate of a real topic. May I request everyone to please stay on the dais? Satish is in a hurry to run away and go to the sun. So may I request the chairperson to please hand over memento to both the speakers. Sir. So the first memento goes to Dr. Amit. Again, put your hands together. We all agree it was a very interactive session. Next memento to our dear friend Dr. Satish. Both have done a wonderful job. I would now request both the speakers to hand over the memento to our chairperson. Satish. Thank you so much. Okay, moving ahead to the next session, we have got a very prestigious chairman's oration, and may I take the honor of inviting Dr. Umesh Khan. Since it is a chairman's oration, there will be no chairpersons in this session. So Dr. Umesh Khan, sir, you start rocking. Time is on.
Good morning, everybody, and welcome to this part of conference. We all know that arthritis is a though common but very neglected part of our clinical study or clinical teaching. But I also know that is a very important presentation before all of us with high morbidity and high mortality. So today I am going to discuss seronegative spondyloarthritis. This is a group of musculoskeletal disorder linked by common clinical feature of common immunopathological mechanism. They are negative to RA factor and mostly involve the axial skeletal. Mostly have HLA-B27 gene. This encompasses 5 types: ankylosing spondylitis, psoriatic arthritis, reactive arthritis, leading to Ritter syndrome, enteropathic arthritis, extraintestinal manifestations of inflammatory bowel disease, juvenile spondyloarthritis, and one is undifferentiated spondyloarthritis. As far as etiology is concerned, there is a classical correlation between prevalence of spondyloarthritis as SPA and the prevalence of HLA-B27 in given population. The strongest relationship is in AS. In the United States, the prevalence of HLA-B27 is 7% of general population, but it is present in 90% of patients with spondyloarthritis, especially ankylosing spondylitis. The PSA, that is psoriatic spondyloarthritis, is associated with multiple HLA molecules including HLA-B27, HLA-DR7, and HLA-DQ3. In inflammatory bowel disease associated arthritis, that is involving Crohn's disease or ulcerative colitis, the HLA association is weaker compared to that of spondyloarthritis, and reactive arthritis
which follows enteric or urogenital infection, has a variable relationship with HLA-B27, with studies reporting anywhere below 50% to 60 or 85%. HLA-B27 is positive in 50% of those with undifferentiated SPA and 60 to 80% those with juvenile spondyloarthritis. The worldwide prevalence of SPA is estimated to between 0.5 to 1.9%. In the United States, AS and non-radiological axial SPA are the most common type of SPA and have combined prevalence of 0.7 to 1.4%. The psoriatic arthritis is thought to affect men and women equally, with a prevalence of 0.01% to 0.2%, and incidence is 0.006%. The psoriatic arthritis is thought to present in 4 to 30% of individuals with psoriasis. Either it appears before the skin lesion or it may follow the skin lesion. IBD-associated arthritis, both axial and peripheral, is present in 3 to 13% of patients with either ulcerative colitis or Crohn's disease. Reactive arthritis is thought to be quite rare. The typical organisms leading to reactive arthritis are Campylobacter, Chlamydia, Salmonella, Shigella, Clostridium difficile. Globally, the prevalence is estimated to 0.03 to 0.04%. As far as pathophysiology is concerned, enthesitis or inflammation of sites where the tendon or ligament insert the bone is a key pathological finding in SPA. This finding differentiates it from rheumatoid arthritis and other inflammatory arthritis. As mentioned above, the major gene involved in the several key pathogenic step is HLA-B27, though there are other non-HLA genes will also be there. Environmental exposure to immune system to microorganisms is also an important factor. Several cytokines have been shown to participate in the inflammatory process. One of the most important is tissue tumor necrotic factor, that's TNF, which is a target for class of drugs used to treat SPA. It is thought that microtrauma from stress also triggers inflammation and enthesis. These inflammatory processes lead to changes in the bone and pathological new bone formation, which is seen in AS but not in rheumatoid arthritis. We'll discuss in short ankylosing spondylitis because it's a prototype and one of the most common. Ankylosing spondylitis or AS is a chronic multi-system inflammatory disorder involving primary sacroiliac joints and the axial skeleton. 90% HLA-B27 positive, man-woman ratio 3:1. Age of onset typically 20 to 40 years of age and more commonly involves axial, though it also involves peripheral joints. Now, this is a new term. The current term of axial spondylitis is used. The disorder affecting axial skeletal with variable involvement of peripheral and extraarticular structure. Again, this is divided into two. First is where the radiological finding is there, known as radiographic axial spondylitis, and second is non-radiographic or radiological axial spondylitis, where the radiological feature is not there, but the diagnosis can be done by MRI. Though in some certain patients, it appears, that is radiographical finding or appear in the later part of the life. The most important sign and symptoms are the backache, usually one buttock or both. Second is fatigue, presence of symptom for more than 3 months and symptom worse in morning or with inactivity. As we have seen, this is one of the inflammatory features. The extra-articular manifestations of AS can be include uveitis, is the more common, cardiovascular disease, pulmonary disease, renal disease, neurological disease, and gastrointestinal disease. No lab test is diagnostic of AS. Rather, any lab test is not very supportive of diagnosis in rheumatological disorder. HLA-B27 is present in 90% patients. This is very important. If you think that it is a case of spondyloarthritis,
seronegative HLA gene testing is very important. ESR, CRP are raised. Mild anemia may be present. Severe disease may show an elevated alkaline phosphatase. Raise serum IgA level. Rheumatoid factor, anti-CCP and anti-nuclear antibodies are absent. CD4 T cells low and serum matrix metalloproteinase 3 level correlate with the disease activity. Along with that, you have to investigate for diabetes, renal disease or liver disease along with these features, this investigation. Now the radiological finding, the diagnosis of AS is generally made by combining the clinical criteria of inflammatory back pain and enthesitis or arthritis with radiological finding. In plain radiograph, sacroiliac involvement is typically bilateral and symmetrical. Usually starts from the lower part of sacroiliac joint and gradually ascends upwards and leads to complete fusion. Spine involvement is often centered at the thoracolumbar or lumbosacral junction. And spine involvement is characterized by osteitis, syndesmoid formation, facet inflammation, and eventual facet joint and vertebral body fusion. Initially, there is an indistinctness and discontinuity of the thin white subchondral bone plate. This progress to gross bone erosion and adjacent bone is often sclerotic and joint space narrowing and bone fusion eventually occur. These are the diagrams showing normal spine, formation of syndesmophytes in second. Third is inflammation of both facet joints and interspinal joints, and ultimately there is fusion. One of the early radiological signs is enthesitis, caused by erosion of superior and inferior margin of vertebral body, resulting in a loss of normal concave contour of the anterior surface, leading to a squaring of vertebral body. Other radiological signs like Siny corner sign or Robinson lesion, Bombo sign, Drager sign, trolley track sign, and Anderson sign. We are not going to discuss in detail. This is the Remsen sign or corner sign, where you see the erosion of the corner of the both vertebra. This is the bamboo sign. This is a sign showing calcification of the interspinous ligament. Dagger sign. Hip joint involvement usually bilateral in distribution. Uniform joint space loss, acetabular protrusion, subchondral cyst, and a ream of osteophytes about the femoral head. Bone erosion and remodeling in the anterior lateral aspect of the humerus, producing a H appearance. On CT, may be useful in selected patients with a normal or equivocal finding of sacroiliac joint radiograph. Joint erosion, subchondral sclerosis, and bony ankylosis are better visualized on CT. Supplements scintigraphy in evaluating area of increased uptake. It is superior to radiograph and MRI in demonstrating injury. Imaging modality of choice in patients with advanced disease having suspicion of spine fracture. MRI, when radiographs are normal or equivocal, MRI can be useful in diagnosis of sacroiliac by showing joint fluid and marrow edema. Superior to CT in detection of cartilage bone erosion and subchondral bone changes. Useful in follow-up of active disease. Synovial enhancement on MRI correlates with disease activity measured by inflammatory mediators. Bone scan may be helpful in selected patients with a normal equivocal finding. Quantitative analysis is more useful. Ratio of SI joints to sacral uptake of 1.4:1 or higher is abnormal. Now the treatment. Since very long time, treatment has changed drastically. Earlier, we used to give the common symptomatic treatment in all of the patients. The peripheral joints used to improve, but as far as the axial part is concerned, the improvement was minimal or there was no improvement. So the treatment start with the physiotherapy or exercise to maintain the movement of the joints, maintain the muscle strength, and thereby reducing the disability as much as possible. Now, once the treatment patient is symptomatic, in spite of this, we used to give NSAID, that is non-steroidal anti-inflammatory drugs, in the form of ibuprofen or other indomethacin or other drugs of this group. No one is superior to other, but maximum dose in a patient, one after another, then only you can think of adding other drugs. But beware of the side effects, especially in bowel diseases or inflammatory bowel diseases. As far as bleeding is concerned, I have seen usually it is familial or not iatrogenic, but non-specific. We have been using NSAID for more than 10 years, 5 years without any symptom. But in a few patients, once you start the drug, the bleeding will start within a week. So start with NSAID. After that, if the patient is symptomatic, then we have to see, or intolerable to the NSAID, then we have to find the other drugs. In axial disease, biologics, that is a tumor necrotic factor inhibitor, are the next line of therapy. 5 TNF inhibitors like infliximab, etanercept, adalimumab, golimumab, and certolizumab are shown to achieve partial or full remission symptom. These are used if started in younger patients, if started with high inflammatory markers, started with low disability, the improvement is much more. But in spite of severe ankylosis or disability, the use of this TNF inhibitor improves the patient practically all features like clinical, subjective or objective, or inflammatory markers in practically all patients. So this is a very important drug in case of axial spondyloarthritis. As other drugs, these are not without side effects. This causes local reaction or IV allergy. It can lead to certain blood disorder like pancytopenia, can precipitate SLE. The patient becomes ANA positive in certain cases, can lead to severe liver diseases, and most important is activation of latent infection in the form of tuberculosis. So before treating, before starting these drugs, we have to be sure the diagnosis. Second, be sure if there is any active disease, and if it is, then you have treated the patient earlier, then you start biologics. The contraindication of the disease of these drugs are active infection, advanced heart failure, lupus, multiple sclerosis, and cancer. Other is secukinumab, a monoclonal antibody to interleukin 70A. It has been recently approved to treat ankylosing spondylitis and has been shown to quite effective in those who cannot tolerate TNF. Third is oral Janus kinase inhibitor or JAK inhibitor, tofacitinib or upadacitinib. These two drugs are also used in a patient who can tolerate TNF inhibitor, or there is side effect of these drugs. But again, while you are using these drugs, we have to be cautious regarding the active infection or acute infection, especially care of herpes zoster. Non-biologics DMRD. These are the drugs which is useful in peripheral arthritis like methotrexate, sulfasalazine, hydroxychloroquine, neosporin, gold, and other drugs. But in recent days, we're using only sulfasalazine and hydroxychloroquine as a DMRD. These drugs may be combined with TNF inhibitors if the same symptoms persist, especially XCL1. Systemic glucocorticoids have limited role in SPA. But in the acute condition, you can use for a few days to make the patient mobile. Otherwise, long dose is not supposed to be given. For IBD-associated arthritis and patients with severe uveitis, the steroid is unavoidable. Localized corticosteroid injections should be used very sparingly due to risk of tendon rupture. It is important to note that although reactive arthritis is usually a self-limiting disease, it can be treated similar to other diseases in SPA family. Surgery is a very last report management strategy. Disease progression is measured by history, physical examination, inflammatory markers, and serial imaging. And last, the take-home message is always try to diagnose these diseases as earlier as possible to reduce the possibility of the morbidity, especially young patients. Thank you.
Thank you, sir. It was a wonderful chairman's oration, and may I request Dr. A.K. Virmani, sir, Chairman Scientific Committee, to please hand over the memento to Dr. Umesh Khan, sir. Thank you. Thank you, sir. Moving on to the next session. क्या हुआ आपको क्या दिक्कत है वो बाद में कर दो इनको तो बुला ले पहले ये तो है ही है May I request the chairpersons for next session, Dr. H.S. Paul sir and Dr. N.C. Singhal sir, to please come on the dais. We are going to have Dr. J. Tripathi oration, and it is none other than the most volatile speaker, Dr. Ajay Kumar. Last evening, Dr. Ajay Kumar was discussing and he told me कि आर्या अगले बार जब ये टॉपिक होगा ना तो इसमें जनरल पब्लिक को भी बुलाना बिकॉज मेरा टॉपिक जो है वो सोशल है इट इज डायबिटीज रिवर्सल वेल टेकन योर नोट सर एंड विल गेट अनदर अपॉर्चुनिटी टू हियर टू यू इन अ बिग मेगा इवेंट ओवर टू यू सर चेयरपर्सन्स डॉक्टर एच एस पॉल सर एंड डॉक्टर सिंगल सर सर प्लीज कम Thank you.
Good morning, friends, and most welcome to this very interesting session. Since this is in the name of Dr. J. Tripathi, one of the senior most and very renowned physician of Jamshedpur, who is no more, passed away in last year, I think. And I'll request Dr. Singhal to say about him in a few words.
Good morning. Late Dr. Jagdish Tripathi was born in 1929 and expired on 2022. Was a renowned consultant physician to reckon with. He died at the age of 93 years in TMS due to multi-organ failure and cardiac arrest. And that brought an end to an illustrious era. Dr. J. Tripathi was born in Jamshedpur, pursued his MBBS from Cuttack Medical College, Orissa, and was a university topper, did his MD in the same college, then MRCP in Edinburgh and Glasgow, and also FRCP from the same place. Then he joined TMH as a house surgeon and later became a HOD of medicine department and professor of MGM Medical College. His contribution in the field of medicine is unparalleled. Dr. Tripathi was a personal physician to then MD, Mr. Rusi Modi, and the then president of the Tata Workers Union, Mr. V.G. Gopal. He was revered for being a caring, hard-working, and an astute physician, and very good clinician, and a great teacher with deep knowledge of medicine, who guided me, and that he treated his patients with utmost satisfaction. He believed in academics and was an examiner in medicine in various national and international universities, Utkal and Delhi universities. He was also a visiting professor to various universities in USA and Europe. He had 7 children, and I think that's enough, and I request Dr. Paul to continue the further proceedings.
Thank you, Dr. Singhal. Let me share some hard facts about diabetes before I ask Dr. Ajay Kumar to take over the dais. I'm talking about in 1970 when I was an intern in PMCH, 70, 71, 72. What treatment and the facility available to assess glycemic control. We used to boil the urine of the patient with Benedict's reagent and no change, nil, from blue to green 1+, yellow 2+, and red 3+, and give injection accordingly. So you can imagine the urine sugar, maybe it was a stored urine, was the only modality of knowing about the glycemic status, and insulin was the only treatment available. Metformins were available, but since it was not very, the immediate glycemic control was not very effective. Later on, its role came to be known. So it was not taken into consideration. The first generation sulfonylureas came, very prolonged action, causing a lot of hypoglycemia. So why I'm telling this, I can claim with confidence, no better treatment was available in Bihar, where Jharkhand was also part of that. Dr. Ajay will agree. The PMCH was the premier institute. Darbhanga Medical College, very good institute was there. Ranchi Medical College was coming up, maybe first or second by Rajapia. And today, in contrast to that, we have a dozen oral antibiotic drugs which have very good effect in preventing cardio-renal problems. We have got almost a dozen varieties of insulin, short-acting, ultra-short-acting, pump, and etc. But still, what is the result? What is the achievement of the healthcare system? In USA, where out of $10, $1 of the healthcare is spent on diabetes, you can imagine, and it's a publications and bringing awareness in the people. Not even 50% of the patients reach target level. That's what I'm talking about USA. In India, the last year's non-communicable disease survey communication and ICMR's result, every 4th person from between the ages of 18 to 69 has impaired blood glucose level. And the incidence of diabetes is approximately 10% with all these complications. But even in this cloud, we are seeing the rays of light about diabetes remission, complete remission, that is cure, and diabetes conversion. So all these things, I think, none can explain in a better way than Dr. Ajay Kumar, who doesn't need any introduction. He's the most sought after speaker at national and international level. And Dr. Ajay is now the dais is yours.
Hello. Dr. Sanjukta is daughter of Dr. J. Tripathi.
Good morning, everybody, and warm regards to everybody. I'm privileged to be given this opportunity to speak something about my father in this oration. You have already heard, and I respect my father, and I believe in following his legacy. Thank you very much. Dr. Ajay will speak.
Honorable Chairpersons, Dr. Pal, Dr. Singhal, dear colleagues, ladies and gentlemen, it's an honor to deliver Professor J. Tripathi oration because for the first time when I came to Jamshedpur in late 90s, it should be 96 or 97, I think, and since then, for several years, in all the scientific meetings at Jamshedpur, he was a towering figure. I had the privilege of speaking in front of him, interacting with him and listening to him. So I think you have done a yeoman's job to start this oration in the name of such a great clinician and academician. Thank you very much. The topic allotted to me for this oration is From Glycemic Control to Diabetes Reversal, a Journey Well Traveled. But before I talk about this journey, let me talk about our journey of last 25 years since I came for the first time to city of Jamshedpur for a lecture. What we have seen is the meteoric rise of Dr. Anil Kumar Virmani at the academic landscape of India. And particularly in the field of diabetes, he has carved a niche for himself which will remind generations of Jamshedpur physicians to come that how hard work, erudite speakership, and a great personality helps an individual to shape his or her career. Thank you, Anil, for inviting me for this great occasion. These are my introductions, which I don't think you need to read, and I have no financial disclosure for this particular topic. When we look at the natural history of type 2 diabetes, I'm sure all of you have seen this slide umpteenth number of times, and all that we know is that you have this great window of opportunity that is something which should strike your attention. We know that over time, in presence of insulin resistance, beta cell function will decline and the blood sugar will rise. But what we always miss on this slide is this great window of opportunity before the development of clinical diabetes. You have the stage of pre-diabetes, obesity, and more importantly, you know the pathogenetic mechanisms of type 2 diabetes. So knowing by this natural history of type 2 diabetes, we are resigned to the fate that no matter what treatment you give to your patient, there will be a progressive decline in beta cell function, beta cell mass, an inexorable rise in the level of the blood sugar. Most of the patients will eventually require insulin, and you can never cure your patient of type 2 diabetes. In fact, most of them are going to land up with microvascular and macrovascular complication. But ladies and gentlemen, this entire concept today is past. Today we talk about diabetes remission and reversal. And let me put into context, reversal is a rather loose term. Somebody's blood sugar is high, it has come back to normal, that is reversal. But the true scientific word is remission, which means that you have the normal level of blood sugar without any pharmacotherapy for at least 3 months. And these are the definitions which have been clearly accepted by all the great bodies of the world, like the ADA, the ESD, the WHO, and so on. And there are multiple papers published in very reputed journals which tell you that if you can bring the blood sugar level to the diagnostic level, and what is the diagnostic level? An A1C of less than 6.5% or a fasting plasma glucose of less than 126, and the patient is not getting any pharmacotherapy for at least 3 months. If you can achieve this, then exactly you say that you have achieved diabetes remission or reversal or whatever you, let's not go into the semantics of the word reversal and remission. Why are we talking today about these words, diabetes reversal? We are talking because today we clearly know the pathogenetic mechanisms involved in the progression of type 2 diabetes. We know the role of glucotoxicity, lipotoxicity, but today I am going to also talk about the twin cycle hypothesis and the beta cell dedifferentiation. Now, why are we talking this? Before the blood sugar and the lipids will come, something else will predispose you to diabetes. And it is your genetic predilection. And when you have the genetic predilection and you develop type 2 diabetes, then glucotoxicity and lipotoxicity will continue to override the existing insulin resistance, and then eventually your beta cells will stop functioning progressively. You cannot do anything about the genetic defect in beta cells which you are born with. But you can do a lot about the next thing, the increased dietary fat. And when I say increased dietary fat, don't take it in a very superficial manner. I will delve much deeper into the concept of this fat into our body and our individual organ systems. And this obviously leads to beta cell dysfunction, beta cell mass, lot of rise in the blood sugar, amyloid deposition, and there are various pathways we don't need to discuss today. What we need to discuss today is this slide. And this is an extremely important slide. If the fonts are smaller and you cannot read the individual words, don't worry. The twin cycle hypothesis means that we have the liver and we have the pancreas. If you are eating a lot, as we all do, the whole world does, then what happens? That the increased positive calorie balance in form of carbohydrate or fat or anything over a background of insulin resistance will challenge the liver with increasing fat content in the liver. And then what will happen to the liver? The normal function of the liver is to allow the insulin to suppress the production of glucose. But because of the presence of this fat, insulin will not be able to suppress the hepatic glucose output and your blood sugar will rise. Same thing will happen when there is a lot of fat. It will increase into the circulation, and then from the subcutaneous fat, it will also trickle down into the pancreatic beta cell. And similarly, what is beta cell supposed to do? In response to food, it is supposed to produce insulin. But because of this fat, the beta cells will not produce adequate amount of insulin, and all will this contribute to the inexorable rise in the blood sugar level and progressive decline in beta cell function. Now just contrast this with isocaloric status, not extra calorie, but nice recommended calorie for you. Then what will happen? The liver will have normal fat content, insulin will suppress the hepatic glucose production, and you will always have normal blood sugar level. Same thing will happen to pancreas, that if you have the normal fat disposition, no fat here, then the beta cells will function properly and you will never develop a rise in the blood sugar level. Based upon this fantastic concept, much earlier Roy Taylor did a fantastic experiment, and that experiment was done with a very, very small number of people, 11 people only, to whom he gave 600 kilocalorie diet and produced a fantastic result of complete remission, and that was more importantly associated with this twin cycle hypothesis that I was referring to. When he looked at the 600 kilocalorie diet, and that led to reduction in the plasma glucose level, it was clearly associated with reduction in the hepatic glucose output and reduced hepatic cells fatty acid content. So very clear correlation that it was the reduction in the fat within the liver cells which was responsible for this decline in the blood sugar level. Same thing happened in pancreas. with 600 kilocalorie diet, first phase insulin secretion improved dramatically and there was a reduction in the pancreatic beta cell content, fat content. So clear correlation that if the fat content will go down both in the liver and the pancreas, your glucose homeostasis will be absolutely normal. What about the insulin secretion? If your blood sugar level will rise and you are a normal person, your insulin level will also rise. But if you are a diabetic, you will not mount this type of response, but a blunted response. And then you go through 600 or 850 kilocalorie diet, then after 1 week, 4 weeks and 8 weeks, look at this. Once again your insulin secretion has come back to the normal level. That is the beauty of this fantastic reduction in the fat content both in the liver and in the pancreas. There are 3 other important things to look at. What we need to look at is the volume of pancreas, morphology of pancreas and composition of pancreas. As compared to normal individuals, diabetic have low volume of beta cells. This is important, that is volume. Now look at the morphology. 78 kg, 94 kg, 75 kg, diabetic and non-diabetic of the same weight. Look at the difference in the contour of pancreas. This is irregular contour of the pancreas, very nice smooth contour of the pancreas. Then here not only alteration but also shrinking of the pancreas, whereas in the normal individuals pancreas is looking healthy, not irregular and not shrunken. That is very essential difference. So I talked about the volume, I talked about the morphology. What about the content? As compared to control, look at the fatty acid content here, and this is clearly much higher in the diabetic subjects. But not every patient of type 2 diabetes will progress to long-term complications or progressive decline in the beta cell function. And therefore, as a corollary, not every patient will respond to your diabetic reversal mechanisms or theories that you will propound eventually, that what I am going to talk today. And what is the best guide to it? It is the correlate beta cell function. At every level of insulin resistance, the beta cell response is much higher in the non-progressors. At this level, this is non-progressor, this is progressor. Even at this level, look at the non-progressor and progressor. There is always a very clear correlation with beta cell function which will determine that which patient will respond. And this has been again very elegantly shown by Roy Taylor, that these are the responders and these are the non-responders. Achieve the same calorie reduction, same fat reduction. Look at the liver fat cells went down in both, pancreatic fat cells both down, but insulin secretion improved in this set of patients, but this did not improve in the other set of the patient. These are clearly the progressors and these are the non-progressors. That has to be kept in mind, extremely important. And then before I go on to the exact methods of diabetes reversal, this another very important concept. I talked about the glucotoxicity, lipotoxicity, and then we talked about the entire concept of fat in liver and pancreas. But I think this very important concept we all know since our graduation days, that in normal individual, when beta cells are challenged with food or whatever, they will nicely produce insulin, and this is the pro-insulin. And our current understanding is that these beta cells over time undergo apoptosis, they die. And therefore, you cannot reverse the diabetes at all. But the modern concept is that they do not die. What happens? They are de-differentiated. They become positive to neurogenin 3, which is a marker. Neurogenin 3 positive beta cells are de-differentiated. That means they are in the process of dying. If you do something, like the measures that I talked about related to diet or others that I am going to talk, then there will be reprogramming and they will not undergo apoptosis. They will regenerate themselves and their ability to produce insulin will come back. So this is an entirely changed concept that we are talking today in terms of this. And we have abundant proof about this. This is a very interesting mouse model which actually, and this is called potassium ATP GOF. And look at the control and those who are untreated and those who are treated with insulin. You can clearly see that there is a very difference in the glucagon positive cells. What happens? We want alpha cells which produce glucagon to be less and beta cells to be more. But in this model, what happens, and this is published in Cell Metabolism, that plasma glucagon level are very high in the untreated patient and goes down when you treat with anything. In this case, it was treated with insulin. Same experiment has been shown in this particular slide, looking at various markers which we as clinicians don't need to go, but clearly tells you that at that earliest stage, if you try to redifferentiate or reprogram the beta cells by effective treatment, it will come back to normal. And this is a very elegant slide which again actually tells you that those neurogenin positive 3 cells which have gone very high will start declining once you start treating. And when neurogenin 3 will become negative, then the beta cell decline will stop. And this is extremely important. All this knowledge translated into an establishment of a very new hypothesis, and that brought out the concept of FOXO1. And FOXO1 is a protein which is required for maintenance of beta cell function. And we know that if you put beta cell under stress, there will be depletion of FOXO, progression of type 2 diabetes, and all its complications. And this knowledge was responsible for the 2017 Banting lecture. You know, Banting lecture is the most coveted lecture in the European meetings. And there it was the modification of FOXO that was possible. They looked at the possibility of modifying FOXO protein, and that will reverse the damage to beta cell. And indeed, there were studies which clearly showed that by modifying the FOXO protein, you increase the C-peptide secretion and you increase the insulin secretion. So today we are talking about hardcore facts about completely reprogramming the beta cell based upon our better knowledge. And this hyperglycemic stress during the critical phase of type 2 diabetes will lead to non-resolution of hyperglycemia, accumulations of toxins in the beta cells, and loss of differentiation, and therefore alpha cells will rise, and obviously your glucose metabolism will be compromised. So you just reverse the process, you target the FOXO protein, completely change the cycle, which has been done in these models, and clearly shown that there is a very nice, this mice did not respond, this responded, because this was programmed through this particular mechanism of preventing the FOXO depletion. This was the scientific part of my talk, that what we have understood in last 2-3 decades in terms of pathogenetic mechanisms of type 2 diabetes, and there are multiple targets which we can actually target to achieve diabetes reversal or diabetes remission. How can we do that? We can do by diet, low carbohydrate, very low calorie diet, exercise, drugs, and bariatric surgery. And we have to look at the data for all of them. And once again, the path-breaking study in this field is the direct study by Roy Taylor, but this time he did not use 600 calorie diet, he used 850 kilocalorie diet. And imagine this was done in private clinics of United Kingdom, the National Health Services general practice. You can imagine the challenge which might have faced, but he did it, and look at the result. The astounding result, how did it was achieved? Total diet replacement for 12 weeks, neutrally competitive, vitamins, minerals, everything were put in a diet which was available to the patient, but it was only 830 kilocalorie. And once you achieved that goal, then there was a stepped food reintroduction. And then after that, diet and exercise were combined together to maintain the same process over a length of time. What do you expect the result to be? Now this is an amazing result which has completely changed the world today. What you can clearly see that almost 1/4 of the patient lost 15 kg. And if you take the total cohort of this particular study, 46% of the patient were in complete remission at the end of 2 years. This is astounding figure, 1 year, I'm sorry. And what is very clear, that the benefit was clearly associated with the increasing quartile of weight loss. If you lost less than 5 kg, 5 to 10 kg, 10 to 15 kg, and more than 15 kg, look at the benefit which is coming. So it is very clear that the more weight you lose, the better outcome you expect, and that is the bottom line to understand the study of the direct result. But then once again, like everything else, From 46%, it comes down to 36% from 1 year to 2 year time. And therefore, this is a very challenging thing, how to maintain that kind of diet. Because to maintain an 850 kilocalorie diet is a very challenging thing. Roy Taylor gave an artificial food formula, but can we translate that into our real day-to-day food pattern? That's a very important question that needs to be tackled. What about exercise and diet combined together? Look ahead trial. Again, astounding benefit, but the same problem that over time, from 1 year to 4 years, there is progressive decline in those who achieved the remission. What about pharmacotherapy? If you give a combination of insulin and GLP-1 receptor agonist, great benefit. The moment you take out the GLP-1 receptor, only treat with insulin, then the benefit goes down over a period of time. And then this led to the concept at the neurogenin 3 positive cells that I talked about, that very early in the course of diabetes, if you give short course of insulin, then you will reverse the beta cell to normal function. And we have number of studies from different parts of the world which clearly corroborate that indeed early initiation of insulin for a only short period of time will reverse the beta cell decline. And then we also talk about the short-term insulin therapy, but the rate of decline is not as sharp as we looked in the look-ahead trial of diet and exercise. So this is something very important and to ponder about. And then the golden goose is bariatric surgery. If you have a BMI of more than 35, or even if you have a BMI of more than 30 with comorbid conditions, and you subject yourself to bariatric surgery, look at the astounding result in the diabetes reversal. And not only reversal, there I was talking about 1 year and 2 year data. Look at the 5 year data, almost a flat line with bariatric surgery. Whether it is only the weight loss or the altered hormonal milieu that is created by bariatric surgery is a question of debate, but a lot of data is now available to understand the exact mechanism by which bariatric surgery helps in reducing this. There are a few emerging treatments also, like the gas-filled intragastric balloon. A very high quality scientific research has come on the duodenal bypass liner and the duodenal mucosal resurfacing. This is completely going to cure diabetes, that is claimed in some of the novel new papers that has been published recently. Fecal microbiota transplantation, that is another very, very promising thing. And all of you know that islet transplantation done in a proper way, in a proper center, has a lot of promise. But of course, these are tools which are in the research domain or in the very earliest stage of the data, but are extremely promising in terms of diabetes reversal in future. Ladies and gentlemen, I am going to conclude my talk by just talking about this new molecule tirzepatide. And what is tirzepatide? It is a GLP-1 and GIP combined receptor agonist. And when you look at the SURPASS data of every dose of tirzepatide, 5 milligram, 10 milligram and 15 milligram, you cannot imagine a result like this. Non-diabetic HbA1c level 5.7% in 50% of the patients in 15 milligram of tirzepatide, and a very consistent result at the end of 1 year time. So what we are looking at, we are sitting at the threshold of a revolution where a combined approach with diet, exercise, judicious selection of oral drugs. I have not talked about other combinations. Even the combinations of pioglitazone and acarbose along with some DPP-4 inhibitor or GLP-1 can be extremely beneficial. But time will not permit me to go into all the trials which have been done to achieve diabetes reversal by pharmacotherapy combinations. But I think it is important to sensitize you that diabetes reversal is not in the realm of fantasy. It's here. And we, not only to our patient, but to the entire community and the whole world, we must tell that there are windows of opportunities which we should just address. We should catch them at that position, advise them, let them know about these scientific developments, that you are creating problem for yourself. If your hepatic and pancreatic fat content is going to be normal, then never at any stage in your life, your beta cell is not going to decline. And I think on this very positive note, I will summarize to tell you that type 2 diabetes is clearly preventable, at least potentially reversible. If you are catching patients within 1 year of diagnosis, 2 years, even 5 years of diagnosis, the chances of reversal are very high. But of course, if it is late, patient is already on combination oral therapy and insulin, it will not be possible. There are role of everything, diet, exercise, drugs, as I talked about, and more importantly, the functional abnormality and the structural abnormality of pancreas today is clearly reversible, as I showed to you in various slides that I shown. Thank you once again for a very patient listening.
Thank you, Dr. Rajai. Excellent deliberation.
Yeah, I know that there are no questions allowed, but if time is not running out, I will be quite happy to take any question. No question? Okay.
Mike, please.
Mike. अच्छा छोड़ दीजिए हम लोग बात कर लेंगे. Thank you so much.
Thank you.
Thank you, sir. Very excellent talk as usual. We all wait to hear Dr. Ajay Kumar time one and again. Big loud round of applause for Dr. Ajay Kumar sir, and thank you for joining us, coming all the way from Patna. Now may I request our chairperson to please hand over memento to our speaker, Dr. Ajay Kumar sir. Dr. Ajay Kumar sir, you told that 800 calories. I will take it with a pinch of salt. Maintaining 800 calories per day, it would be very difficult, sir. Very difficult. Thank you. May I request our speaker to hand over memento to our chairpersons, to Dr. N.C. Singhal, and another one to Dr. H.S. Paul sir. Once again, big thank you to the whole team. Well, friends, moving ahead, we are going to witness now another debate. This is debate number 3. And may I request our moderator for this session, once again, Dr. Puneet Saxena, to please come on the dais. There are 2 speakers, Dr. S.S. Dharia and Dr. Arun Kedia, to also please join on the dais. The topic is, should we treat asymptomatic hyperuricemia? Dr. Dharia will be speaking in favor, and Dr. Arun Kedia would be speaking against the motion. Chairperson, sir, all yours.
Thank you very much. We move on to debate number 3, and the last debate we had on vitamin D. The same question again arises to clinicians, that whenever they are dealing with the patient, especially the chronic segment patients, the uric acid level bothers the patients as well as the clinicians. And it poses a question whether we should treat asymptomatic hyperuricemia or not. And we have to take a decision. If you don't take a decision, many a times the patient asks that what is to be done to this problem. So to hear out, we have Dr. S.S. Dharia will be speaking in favor of the motion that we should treat asymptomatic hyperuricemia, and Dr. Arun Kedia from Chhattisgarh that he will be speaking against the motion. So Dr. Dharia first.
Thank you so much, sir. So this is a right question. Somebody is entering in your clinic and he is coming with the uric acid level. Sir, it's 9 or it's 8 or it's 10. What should we do? So I'll be speaking on should we treat or not hyperuricemia. So hyperuricemia is a common disorder that affects all ages and genders, and the most common manifestation of the hyperuricemia is gout and uric acid urolithiasis. In asymptomatic, there is only urate level is increased, but there is no symptoms, and the uric acid lowering therapy initiated in cases of symptomatic hyperuricemia, but the frequent condition of asymptomatic hyperuricemia remains a challenge. Regarding the prevalence, that hyperuricemia is increasing in since last 40 years, and mainly in Asian countries, there is a almost 21% in the general population, and hospitalized patients are 25% having the hyperuricemia. The normal serum uric acid levels are 3.72 in a man and postmenopausal woman, and in premenopausal woman it's 2.6 to 5.7. And if it is more than 6.8, it starts crystallization, and that classified between symptomatic and asymptomatic. In symptomatic, you will have a gout, urolithiasis or acute nephropathy, and in asymptomatic, there is only urate level is increased and there is no symptoms of the gout and all. So come to the mechanism, how hyperuricemia occurs. There is a dietary purines or endogenous purine synthesis by the tissue nucleic acids. They convert into the urate. It's a complex mechanism where the ATP, ADs and all converts into the urate. This serum uric acid is termed as a urate, so I will speak as a urate. If there is a overproduction of urate or there is a under excretion through the kidneys, that both leads to the hyperuricemia. And in overproduction, there are some clinical disorders where the obesity, insulin resistance, high cell turnover, the Down syndrome, tissue ischemia and hypoxemia. There are some genetic disorders where you can have the overproduction like SPRT deficiency, some glycogen storage disease also causes overproduction. And in diet, the ethanol, seafood, meats, vegetables, fructose and some cytotoxic agents also causes overproduction of uric acid. The under excretion, or it means is your renal failure. The excretion of uric acid is impaired. In that condition, you will have the hyperuricemia. There are some genetic disorders where the mutations occur and they causes the under excretion through the kidneys. The uric acid is mainly excreted through the kidneys 70% and 30% through the gut. And ethanol and fructose can both cause the overproduction and the underproduction of uric acid. This all leads to the chronic kidney disease, atherosclerosis, gout, stroke, hypertension and the cardiovascular diseases. So I already discussed this causes the both exogenous and endogenous source of purines. They convert into the uric acid via the xanthine oxidase enzyme, and the absence of uricase or some additional genetic variants at the excretion, as I told you that 30% is excreted through the gut and 70% from the kidneys, where there is a decreased uric acid renal excretion. And in Western diet, where the high in sugar, purines and alcohol, there is overproduction of the uric acid. The complications. The main complication of uric acid elevation is your gout, where it increases with the age and degree of hyperuricemia, and urolithiasis, it may prevalent 0.01 to 10%. And the increase in uric acid production leads to hyperuricemia, where you can have a acute uric acid nephropathy in some syndromes like tumor lysis syndrome and in lymphoproliferative disorders. The controversial complications of hyperuricemia. Here you can see the vice versa. The hyperuricemia can cause the CV disease, the stroke, renal disease, metabolic syndrome and the hypertension, but these also can have the hyperuricemia where you can have a asymptomatic hyperuricemia. So in metabolic syndrome, the prevalence is increased substantially with the increased level of uric acid, and there is a 1.6 time increased risk of developing metabolic syndrome. And in regarding the cardiovascular disease, it is associated with an increased risk of developing hypertension in following 5 years, regardless of other risk factors like smoking, alcohol and all. And it is closely linked with the hyperuricemia with a relative risk of 1.13 for every 1 milligram per deciliter increase in the serum uric acid level. And in renal disease, if it is more than 7, that multiplies the risk of end-stage renal disease by 4 in men and 10 in women. There are some epidemiological studies have confirmed that the increasing serum urate levels are associated with the impaired EGFR and increased hazards of developing incident CKD. So come to some evidences where hyperuricemia. This is a beautiful study mainly in Indian obese patients, and they have said that the 40% of the patient who had the hyperuricemia presented with the hypertension as compared to 30% normal urosemic patient. This is again the study, epidemiological study, where the without comorbid patients of asymptomatic hyperuricemia, there is a significant risk of developing hypertension, dyslipidemia, overweight, obesity, and CKD, and a non-significant trend for developing diabetes in asymptomatic hyperuricemic patient. The silent monosodium urate crystal deposits, they are associated with the severe coronary calcification. There is an exploratory study, and it is a beautiful said that the moderate to severe coronary calcification was higher in the patient with asymptomatic hyperuricemia with the monosodium urate crystals. And how it occurs? The monosodium urate crystals, they are basically do this through the inflammasome pathways. They are the crystal dependent and the crystal independent mechanism by which they trigger the pro-inflammatory pathways. Through that, they increase the risk of coronary calcification. In acute renal failure, serum uric acid, it's not only a marker, but it contributes to the pathologically to renal vasoconstriction as well as the endothelial dysfunction, inflammatory response, oxidative stress, and disturbances in the autoregulation that occur with the acute renal failure. The role of asymptomatic hyperuricemia in the progression of CKD and cardiovascular disease. Here you can see that there is a significant risk of cardiometabolic disease which play a contributory role in causing these both CKD and the CV disease. Association between the osteoarthritis and asymptomatic hyperuricemia in OPD patients. This study was published in European Review for Medical and Pharmaceutical Science, and there is a asymptomatic hyperuricemia as a common comorbidity among older patients who presented in your OPD with the knee osteoarthritis. The mortality, how it affects through the asymptomatic hyperuricemia. Here you can see that there is a significant increase in the risk for all-cause and cardiovascular mortality was observed in men with serum uric acid level more than 7 or less than 3 in both men and women. The independent risk factor for MI in adult population, which was a 4-year follow-up study, and in that they says that the incidence of MI that did not result in the death was significantly higher than in the non-hyperuricemic group, 1.6 versus 0.7%. And these asymptomatic individuals have an increased risk of non-fatal MI even in the absence of traditional risk factors like smoking, hypertension, diabetes, and so on. So, after accumulating all these evidences which suggest that asymptomatic hyperuricemia contributes to the comorbidities with which it associates, that proper asymptomatic hyperuricemia treatment may reduce the future risk of all these diseases. Although there are clear recommendations on the treatment of gout with urate lowering therapy, the management of asymptomatic hyperuricemia remains the controversial. So this is the IDEA consensus statement, the Integrated Diabetes and Endocrine Academy, which clearly says that asymptomatic statement is regarding the treatment of asymptomatic hyperuricemia. So if it is more than 6.8 milligram per deciliter, then treatment should be started primarily with the non-pharmacological therapy. The dietary restrictions, moderate exercise, weight reduction, avoiding modifying drugs which causes hyperuricemia. And if it is between the 6.8 and 8.9, then look for the renal functions. If renal functions are normal, then no need for a urate lowering therapy. And if there is a involvement of your kidney disease, then we have to start the urate lowering therapy. But if it is already more than 9, then no need to look any renal function or anything else, just start the urate lowering therapy. The efficacy and safety of the urate lowering agents and asymptomatic hyperuricemia, beautifully presented by this systemic review and network meta-analysis of RCT. They say that the identical beneficial effects of urate lowering therapy on the composite renal events and EGFR, but not for the other outcome. So that is only for the EGFR or the renal outcome. Both allopurinol and febuxostate lowers the composite renal events. So they are useful in asymptomatic hyperuricemia. This is urate lowering therapy in the CKD patient, where 832 patient showed the benefit with this urate lowering therapy by retarding the fall in EGFR in the treatment arm. So again, the urate lowering therapy treatment on the hypertension. So once if you are giving an urate lowering therapy in a patient who are having the blood pressure, if you will see the blood pressure, there will be the decrease in systolic blood pressure whether he or she is on antihypertensive treatment or not. So to summarize, the people who with asymptomatic hyperuricemia are at a significant risk for a cardiometabolic disease. Lowering the uric acid therapy may play an important role in delaying the progression. Non-pharmacological treatment with diet, restrictions and exercise is recommended for all patients with asymptomatic hyperuricemia. And also the low dose urate lowering therapy should be initiated in patient to mitigate the complications. So given the renal, cardiovascular and cerebrovascular benefits from the normalizing serum uric acid level with urate lowering therapy, the question should not be if, but rather when patient should be started the therapy with hyperuricemia. Thank you so much for patient hearing.
Thank you, Dr. Daria. And now we have Dr. Arun Kedia.
Good morning to all, and thanks for inviting me to Jamshedpur. So in continuum with the talk that is going on, I first congratulate Dr. Darius to give a brilliant talk on the points why he wants to treat asymptomatic hyperuricemia. So this is what I am, and I have no financial disclosures, but I want to disclose that Dr. Sher Singh Daria and me are very, very close friends. And this is a recent pic of my visit to his family at Jaipur just a month back, and we had a great gala time. At the same time, I have a humble ambition. Today, I am fighting with a Sher. I am fighting with a double Sher, Sher Singh. And so, you know, I am trembling. And you saw, even these lights trembled and it fell down because Dr. Daria was sitting here. So, with great humble submission, and with respect to the moderator, I already say that the crown should be on Dr. Daria's head, though I will try to fight with a very, very mild submission. So coming to this million-dollar question, that asymptomatic hyperuricemia, whether to treat or not to treat, I still feel it is a very genuine question, and it will remain a question pertinent for years, maybe till we find a very good evidence in favor of hyperuricemia leading to all such comorbid conditions which Dr. Daria clearly mentioned. So first of all, we already know that there is a heterogeneity in the definition of asymptomatic hyperuricemia. So if you see the ACR, the EULAR, the Japanese guidelines, and then the IDEA consensus, there is slight difference in the uric acid levels where they call asymptomatic hyperuricemia. And we should understand that there are factors which determine this uric acid levels. It could be race, it could be age, sex, time, and the lab technique. So we are still not very clear what is the right technique to measure uric acid, what is the right level in a particular race, what is the right level for a particular age, and then we are trying to treat asymptomatic hyperuricemia. So these are the possible consequences which Dr. Daria already spoke. And then he very nicely spoke that there is controversial consequences. And these controversial consequences that he already mentioned in his slide were the cardiovascular disease, the hypertension, the myocardial infarction, the obesity, insulin resistance, type 2 diabetes, and metabolic syndrome. So we still must take this with a pinch of salt, whether uricemia is really a causal factor for all these syndromes. At the same time, we must also remember that uric acid has a double phase. So lowering uric acid may not always be beneficial. So uric acid, on one hand, is an antioxidant. It is a natural antioxidant in our body, which has replaced vitamin C levels to a certain extent. And at the same time, a higher level may cause a pro-oxidant effect. And so lowering serum uric acid may not always be beneficial. It may sometimes do harm, and there are studies which have shown that if you bring down uric acid too low, then probably you may have a neurodegenerative disorders. You can have dementia, you can have Parkinson's disease. So the question again arises, do all patients with asymptomatic hyperuricemia develop gout? So I would come with this data that only 15 to 20% of people with asymptomatic hyperuricemia would develop gout. And hence, uric acid is not the only risk factor for developing gout. The other risk factors have to be taken into mind, and these are increasing age, male gender, increasing BMI, the dietary factors, the genetic factors, and the drugs. So it could be iatrogenic also. So why do you have to label everything to hyperuricemia? The gout could be even there, even in the presence of a normal uric acid. Now coming to evidences of hyperuricemia and CKD, let me take you to this publication, which was a randomized controlled trial published in American Journal of Kidney Disease. It states that febuxostat therapy for patients with stage 3 CKD and asymptomatic hyperuricemia, and you can see the conclusion. Compared to placebo, the febuxostat did not mitigate the decline in kidney function in patients with stage 3 CKD and asymptomatic hyperuricemia. So the role is over. Again, if you see the studies with allopurinol, again the conclusion from this study in NEGM published in 2020, you can see that in patients with CKD and a high risk of progression, urate-lowering treatment with allopurinol did not slow the decline in eGFR as compared to placebo. So again, it is smashed. This is another very important study published in Journal of American Society of Nephrology 2020. Again, a recent study which again concludes that asymptomatic hyperuricemia does not affect CKD progression unless uric acid crystallizes in the kidney. And I told you, uric acid crystallizes due to multiple reasons. It is not only to the level of uric acid. So uric acid level does not correlate with the uric acid crystallization. You need to have other factors to cause crystallization, and that is why it is not important that we can make an inference that all uric acid leads to CKD progression. This was another editorial published in Kidney Research and Clinical Practice, again a very recent editorial of 2019, to treat or not to treat asymptomatic hyperuricemia and chronic kidney disease. And what you can see very clearly, they say allopurinol, though used for 50 years, the adverse effects are still high, and it is seen in almost 3 to 5% patients. And if the patient develops allopurinol hypersensitivity, the mortality rate is almost 20 to 25%. At the same time, the CARES trial came, which smashed the cardiovascular safety of febuxostat. And it says that the cardiovascular safety of febuxostat revealed that all-cause and cardiovascular mortality were higher in patients using febuxostat over allopurinol. So again, we are probably going to do more harm than benefit. So in conclusion, all the studies, they say that considering the side effects of urate-lowering drugs in patients with CKD and the lack of clinical trials showing a real protective effect in patients with CKD and asymptomatic hyperuricemia, it would be premature to recommend this therapy right now. Then we had discussions on hyperuricemia and cardiovascular diseases, and Dr. Daria sir already claimed that all asymptomatic hyperuricemia to be treated in order to decrease the risk of diabetes, to decrease the risk of MI. He also showed that there is a decrease in the risk of fatal myocardial infarction. But he must also answer this question, that is it only a causal association or it is just casual association? So it is unknown whether hyperuricemia is a causal factor in development of all these conditions, and unless and until we prove it that it is direct causal, uric acid lowering is unlikely to be a successful strategy for the treatment of all these comorbid conditions. So this has to be taken into mind. And this causal or casual, this depicts very clearly, which I would like Dr. Daria, my opponent, to read, that everybody who went to the moon has eaten chicken does not mean that chicken makes you go to the moon. So, you know, hyperuricemia cannot be just a factor that you can shout that it leads to all these comorbid conditions. And then if you want to analyze scientifically, then as in the morning we had a debate in vitamin D, we also talked about this Hills criteria for causation, and all these factors in the Hills criteria need to be satisfied before you label that uric acid is a causal factor for all these comorbid conditions. I would not go into the details of all these criteria, but it is very pertinent that we need to analyze all these epidemiological criteria before we call hyperuricemia as a causal factor. This is a recent study which again says that febuxostat does not delay the progression of carotid atherosclerosis in patients with asymptomatic hyperuricemia, and this was a study in Japan done for 24 months, and they found that there was no delay in the progression of carotid atherosclerosis despite lowering of serum uric acid with febuxostat. So again, this study does not support febuxostat therapy for just lowering the cardiovascular risk. We are now in the world of evidence-based medicine, and I have given you even enough evidences to say that probably we are not going to treat asymptomatic hyperuricemia just to lower down the risk. At the same time, we need to have the best available evidence, the clinical judgment, and most important is the patient values. Patient value has to be taken into account, and this is what we need to understand and remember at every step we treat our patients. The first thing, the first principle is first do no harm. So that is why it is important to understand that we need to also keep in mind all the adverse effects of urate lowering therapy in patients with asymptomatic hyperuricemia. And just imagine if your patient, you have prescribed allopurinol and he develops this type of hypersensitivity reaction, lands up into ICU, leading to almost 25 to 30% mortality. You are just fired a patient who was asymptomatic. So treating with allopurinol may not be always beneficial. Dr. Daria may say that we have tests for finding out whether the allopurinol hypersensitivity patient is prone or not. But I'll just ask him that this HLA-B testing, how far and how common can you do for each individual patient who comes to your clinic? It's almost practically impossible. Also, we need to understand that it is necessary to avoid polypharmacy. So you can see very well clearly, that patient says they didn't know what was keeping me alive then. You give so many drugs, the patient does not know what is keeping them alive. And this patient, when you de-prescribed, he says, but I feel much alive now. So same thing we did for vitamin D today. Vitamin D, again, we thought that, it's a hype drug. Same thing, I think treating asymptomatic hyperuricemia may be more of a hype. And we all know the consequences of polypharmacy. The most important would be the low adherence. And if you treat asymptomatic hyperuricemia, probably the patient might skip some very important drug. He might skip a statin or he might skip an aspirin for his comorbid condition and might feel that febuxostat is a more important drug than taking a statin. So keeping all these things in mind, we must avoid polypharmacy and try to be very judicious in trying to treat asymptomatic hyperuricemia. So don't treat hyperuricemia with drugs is not only the statement given by me, but it is by also William Osler, who says one of the first duties of the physician is to educate the masses not to take medicine. So go for more and more of conservative therapy, more lifestyle modifications rather than trying to jump to prescribe a drug. I'm not trying to tell my opponent that he's farmer driven or I'm not alleging any allegations on him. But then he must be justified in writing or prescribing drugs for asymptomatic hyperuricemia. And at the end, this is the most important paper that I would like you all to highlight. This is an umbrella review of 57 articles reporting 15 systemic reviews, 144 meta-analysis, 8 articles reporting 31 meta-analysis, and 107 Mendelian randomization studies. And what it concludes, that despite 100 of systemic reviews, meta-analysis, Mendelian randomization studies, which explored 136 health outcomes with uric acid, the convincing evidence of only clear role of uric acid lies for gout and nephrolithiasis and none of the other comorbid conditions which my opponent described to you all. This was the flowchart which he mentioned. And he says serum uric acid more than 9 only should be treated with urate lowering therapy, but this is only one of the idea consensus. But if you see that most important part is the non-pharmacological treatment, which is much higher than treating with urate lowering therapy. In this modern era, when we have treatment in terms of more important diagnostics, if you can do an ultrasound of the joints and if you find that there is a crystal deposition, or if you can do a urine sedimentation and look for crystals in it, then probably you would be justified in trying to treat asymptomatic hyperuricemia wherever there is evidence of crystallization. But otherwise, I don't think there is any consensus which says that asymptomatic hyperuricemia needs to be treated with urate lowering therapy. So these are the very clear conditions for which we have evidence for considering the use of urate lowering therapy for asymptomatic hyperuricemia. Condition number 1, my opponent, please note, in the presence of persistent uric acid levels higher than 13 in men or 10 in women, in the presence of urinary excretion of uric acid exceeding 1100 milligram daily, and in the presence of patients about to receive radiation or chemotherapy, and this comes from a critical appraisal 2020 from European Journal of Internal Medicine. So this is probably the most convincing conditions where I would like to treat asymptomatic hyperuricemia. So to conclude, the use of urate lowering therapy is not supported by conclusive evidence from prospective randomized controlled trials, nor it is recommended by any of the guidelines. The reduction of cardiovascular risk, as per what my opponent said, would imply long-term or probably a lifelong exposure of a large and varied population with a drug which has multiple adverse effects. Treating asymptomatic hyperuricemia for years or decades, aiming to avoid the development of gout or nephrolithiasis, which might not occur anyway in the patient till he dies. Again, it is not justified. And if you want to justify yourself, I would advise you to go for more long-term data, or you come with more data on safety and pharmacological interactions, which will help the clinicians to be carried by your false notions that asymptomatic hyperuricemia needs to be treated. So with that submission, I put the decision into your court and the court of the moderator to decide what should be the right answer to this question. Thank you all.
So thank you very much both the speakers, and I invite you on the dais to, and you are allowed 2 minutes for rebuttal or cross question each other. So Dr. Daria first.
Yeah. Thank you, sir. So as my opponent already, he also agrees that we should treat the asymptomatic hyperuricemia. He has already shown this slide. If it is more than 9, and there are 3 points he has shown everybody. So what I suggest you that the uric acid, earlier it was an oxidative antioxidant, that only in the range of 3.7 to 5.8. So once if it goes to higher, it is like 8 or 9, then it becomes the pro-inflammatory. So there is a pro-inflammation occurs, then there is a uric acid crystallization occurs in your renal tubules. So one is oxidative stress, that was right, but in higher quantity it becomes a pro-inflammatory. So it causes damage to the your renal tubules. Second, he has already agreed that the asymptomatic hyperuricemia should be treated, but as he shown the allopurinol. So there is only not a single allopurinol drug is there. You can use the febuxostat. And regarding the adverse events of the both drugs, I think there is not a single drug which is not having the side effect. So any drug can have a side effect, so it is not meant to that we should not use that one. So
Dr. Arun?
I think I don't have any words to rebut because I was very clear in my slides. I want my opponent first to answer whether the association of hyperuricemia with all the conditions that he has mentioned is really causal. If it is causal, I would definitely submit in front of him and I would say, yes, I accept my defeat. So first, I need the proof that hyperuricemia is a causal factor. Second, if you have gone through his slides, all the slides have shown the controversial issues related to hyperuricemia, and it is clearly mentioned that all the comorbid conditions which he enumerated are controversial. So I still feel that it is a controversy, it is still not a consensus, and we should come with this notion to treat asymptomatic hyperuricemia till we have a very robust data that if we treat asymptomatic hyperuricemia, we will have a benefit on the hard endpoints of cardiovascular mortality, or what he showed in terms of osteoarthritis also. I don't think there are any studies which says that if you treat asymptomatic hyperuricemia, you will reduce osteoarthritis.
Yeah.
Thank you.
So, okay. Just the last.
I want to say one thing, sir.
Just the last
there
comment.
there is a 5-year cohort study which was done in the Japan, and on the basis of that study in Japan, they have included.
So let's wind it up. So the house is open and the people can ask questions also in last, but few questions in yes and no to both of you. So is the causal relationship of uric acid well established and proven? Yes or no?
Yes.
No. The audience has seen the data and the trials which we have shown. If you have to treat asymptomatic hyperuricemia, is there a universal consensus? Because what Dr. Arun showed was the cutoff level of 13 and what you showed was the cutoff level of 9. So why there is such a huge gap in between the two values? And do we have any Indian data?
I think we need more studies regarding that, the cutoff point. This cutoff point 9 was studied in Japan, 5-year cohort study, and on the basis of that study in Japan, they have recommended the treatment of asymptomatic hyperuricemia if it is more than 9.
So, Dr. Arun, you have to say anything?
So I showed in my first slide that there is a vast heterogeneity in the definition of asymptomatic hyperuricemia. That is in the first step. Second step, if you go through all the guidelines.
So Japan is the country where from where the maximum work on the uric acid has been done, and the Japanese guidelines, although they exist from 2010, but they still hold the same values for the treatment of the asymptomatic. The last question is, if you have to treat asymptomatic, till how long? Will the treatment continue for life? How long? Both of you.
I would not treat. I have very clear indications that I would treat only when there is a very important association, that there is evidence of crystallization, or what I have shown that there is a risk of deposits of crystals in the joints.
So I think we conclude over here, and the take-home message probably is that asymptomatic hyperuricemia has been noticed of late with the increase of metabolic diseases as a marker and postulated as a causative agent for chronic diseases also it propagates. And there are guidelines which tell you that one should treat with the drugs available, but the question is how long to treat. Nobody has an answer, and probably if there are compelling indications like gout or kidney involvement, then obviously one needs to treat, and regarding the gray area, one has to take a call on individual basis. Thank you very much.
Thank you. Just because this topic was really very controversial, so I had given this topic and both have done justice to it. But in the end, we must have a consensus, because and what is the consensus? Consensus is that obviously if you have hypersemia and joint pains and gout and all that, we are not talking about, that is to be treated. As far as asymptomatic hyperuricemia is concerned, if it is, you must have a cutoff. And we know the normal level cutoff is around more than 7. And if it is more than 9, obviously you have to treat, as he has rightly said. The problem is between 7 and 9. What do you do? A gray area. Now, if the patient is asymptomatic in the sense that he comes to you with a report of say around 8 serum uric acid on routine health checkup, he has come to you, and we see a lot of patients and they ask, sir, mera uric acid bada hua hai, treatment de dijiye. Now that is a gray area. What should you do? If the patient has certain comorbidities like obesity, metabolic syndrome, diabetes, hypertension, obviously you won't hesitate in treating him. But in this gray area, the consensus should be that you put him on, modify his diet. That should be the first step. Tell him to stop non-veg, no alcohol. And then if there are secondary causes, try to treat the secondary causes. The last step is if you patient really wants a drug, then it should be shared decision making. He has shown a very grim picture of allopurinol side effect. All drugs have very huge side effects, so you have to have a shared decision making with the patient. Don't take all the credit on you for giving the drug between 7 and 9. There is a gray area and there are no answers. So you have to have document, discuss with the patient agreed to take drug. Finished.
Thank you, sir.
Thank you, sir. Thank you.
So we can have a cutoff of 7, 8 and 9. So above 9 one can treat, 8 with complications, and below 7 if the patient has gout or kidney disease. So 7, 8 and 9 can be taken as the values.
Thank you so much. I think Dr.
After 9 we have to treat. Not lifelong, because the trials with the febuxostat and other documented data is only for 3 months. So the safety beyond that point of time is not well established. Yeah, so that's a gray area. It depends on the discretion. Yes, but that's a true thing. But I think with diet modification and other things, one can control many patients.
Treatment
includes... I think we all would agree that we would have further discussion during lunchtime. Thank you so much to both the speakers and the chairperson. May I request the chairperson to please hand over memento to both the speakers. Please come at the center of the dais. So the first memento goes to Dr. Daria. Clap, clap, please. Lot of efforts are being made by all the speakers. Thank you so much. Another memento to our Dr. Kedia. Sir ka hai? Okay, memento to our chairperson from both the speakers. Thank you so much. Moving ahead, we are going to the next symposium on heart failure. May I request our chairperson for this session, Dr. N.K. Das sir, Dr. Abhay Krishna if he is here. We have not seen. Oh yeah, please join. And Madam B.R. Master to please come on the dais. Dr. Mundra to please, Dr. Mundra sir to please escort Madam Master on the dais. There are slight changes in the sequence in this symposium. The first speaker for this would be Dr. Puneet Saxena. Second speaker would be Dr. Deepak Gupta. And third speaker is our very own Dr. A.K. Virmani. So there are certain changes, chairpersons to please note. I repeat the change of the sequence for the chairpersons to please note. The first speaker is Dr. Puneet Saxena. Second speaker is Dr. Deepak Gupta from Ranchi. And third speaker is Dr. A.K. Virmani. Chairpersons to please note. Okay. Thank you. Chairpersons, all yours.
Thank you. Good afternoon. This is a very important topic we are going to discuss now. This is regarding heart failure. And I think all the aspects have been taken care of. Now, our esteemed speaker, Dr. Puneet Saxena, is there to speak about HFpEF. How, and it's not an orphan. Let's hear from him, Dr. Puneet.
So, thank you, honorable chairpersons, and thanks once again to the organizing committee, Dr. Virmani. And we all know that heart failure is such a big problem. It's elephant in the room, and the magnitude of the problem is increasing every day because of the chronic problems, and it's a terminal event, whether the person is suffering from hypertension, diabetes, or coronary artery disease, or maybe cardiomyopathies or use of drugs, and even the infections which are leading to myocarditis and so on. So it's the terminal event. We need to understand more about this. And since our graduation days, we have been reading heart failure, whether it's the systolic heart failure or the diastolic heart failure, or the forward or the backward heart failure, the congestive heart failure. So many things have been done. But we all should understand, and I am also part of it as a clinician, that whenever the ejection fraction or the systolic function is lost, we clearly label patient as heart failure. So that is the common concept with the postgraduate students and even we clinicians. And this is the entity, heart failure with preserved ejection fraction, which has been left and lesser understood and more probably lesser paid attention to it, and it was left as an orphan for many, many years till the technological advancements have been done to identify it and to address it in a better way. So it's no longer an orphan nowadays, and we have guidelines and we have diagnostic criteria. So heart failure patient with LV ejection fraction of more than 50%, so it can be 60 also, it can be normal also, are considered as heart failure with preserved ejection fraction, and it refers to heart failure symptoms. Please note, symptoms with normal or near normal cardiac function on echocardiography. And the features are diastolic dysfunction, reduced compliance, and ventricular hypokinesia, which should be detected based on the symptomatic complaints of the patient. It's the progressive syndrome with preserved ejection fraction, and it's characterized by complex mechanisms, systemic and cardiac adaptation that may vary over time, particularly in the elderly population. And the progression is modulated by existing conditions like coronary artery disease, renal disease, and the structural and the function alterations in the myocardium, and then the neurohormonal alterations by activation of the sympathetic system and the RAS axis. So there have been guidelines. The European Society of Cardiology, they differentiates clearly between the three conditions: the heart failure with reduced ejection fraction, where the symptoms and signs along with ejection fraction of less than 40; the heart failure with mildly reduced ejection fraction, where the symptoms and signs with the ejection fraction between 40 and 50, but with elevated levels of natriuretic peptide, that is pro-BNP and BNP, and at least one additional criteria like relevant structural heart disease like LVH or left atrial enlargement and diastolic dysfunction. And you come to the third category which we are talking today, that the heart failure preserved ejection fraction, the symptoms and signs along with elevated levels again of BNP and pro-BNP, and the same structural and functional dysfunction of LV or LA along with diastolic dysfunction. But please note, the symptoms of all these three heart failure are similar: shortness of breath, excessive tiredness, and limited exercise capability. And if you see the difference between the two main categories on the other end, the reduced ejection fraction, the basic pathophysiology reduction of systolic function, men affected more than women in younger population with more common history of myocardial infarction and dilated cardiomyopathy. And ILV is dilated with eccentric remodeling, and vasodilators like ACE inhibitors, they improve the systolic performance, and myocardial stress injury is more pronounced. Whereas in the heart failure with the preserved ejection fraction, you will find that there is an alteration of LV filling. Women are affected much more than men, more often older people, and with history of hypertension, AF, and ventricular heart disease. And this is very common. Hypertension, the rhythm disorders with longevity, we are finding it much more often. Impact of comorbidities may be more profound, like diabetes or any other metabolic problem. Then concentric remodeling with or without LVH, and vasodilators have little or no impact on the LV systolic performance, and myocardial inflammation and fibrosis are more prominent here. So this is how the heart failure with preserved ejection fraction progresses from risk factors to clinical syndrome. It's a busy slide, but I'll try to sum it up. The risk factors are aging, obesity, metabolic syndrome, hypertension, sedentary lifestyle, coronary disease, and kidney disease, which one can anticipate in any elderly people who are suffering from these ailments. and it leads to changes in the tissue and the cell pathology, which leads to left ventricular hypertrophy and reduced volumes in the diastolic phase, and finally the dilatation. And it leads to decreased inotropy, lusitropy. Lusitropy is abnormal relaxation of the ventricle, and decreased chronotropy. And finally, it leads to the symptoms and the condition of heart failure. If we see the epidemiology of this condition with preserved ejection fraction, the prevalence is almost 30 to 50% in the hospitalized patients because of heart failure. So huge numbers also, and proportion of patients with ejection fraction of more than 40% is generally close to 50%. So its reduced ejection fraction is on one side 50%, with almost normal ejection fraction is 50%. And they are more older and females are more affected. If you see the Asian data, so this was the Asian heart failure registry, which studied the burden of heart failure with ejection fraction in Asians, and it was said that the Asian continent, because of increased CV risk factors, are sitting on an impending epidemic of this condition. And if you see the comparison of mortality and hospitalization in this class of patients, it is 2.68 times higher risk of death or heart failure hospitalization at 1 year in Southeast Asian population. And if we see the Indian data, that what is happening in India, then you will be surprised that 1 out of 4 heart failure patients are with preserved ejection fraction of the total burden, and prevalence of risk factor, diabetes and hypertension are being more prevalent in India. So in the coming years, maybe we will see this condition more and more. And again, more prevalent in females. And important to note here is that in Indian population, they are presenting at the younger age compared to those in the West, and prognosis of heart failure patients appears to be worse than in the West. So this was the age distribution ratio, and you will find that in the Indian patients, the majority of the patients were less than 55 years of age. And this is the mortality data for the Indians with preserved ejection fraction heart failure, where mortality rate is close to 35% at the end of 1 year. And there are factors which can increase mortality, like history of stroke, high creatinine, then one or more hospitalizations and suboptimal treatment, which we see quite often in our part of the world. We come to the diagnosis, what happens? Start with the symptoms and the signs, the third heart sound, the pulmonary congestion, the edema, the hepatomegaly. The symptoms and signs are same in all types of heart failure, and so is in this condition. And the clinical characteristics are that majority of the patients are women, hypertensives. Then coronary artery disease is more common with heart failure with reduced ejection fraction rather than this condition, and diabetes predisposes to all kinds of heart failure equally, whereas obesity, again, the heart failure with reduced ejection fraction is more. So what do the guidelines say about the international guidelines recognize the complexity of diagnosis, non-specificity of symptoms, and need for objective evidence. And we see here that the symptoms typical of heart failure, signs typical of heart failure, and only normal, only mildly reduced LV ejection fraction patients should be taken care of, and they should be investigated for natriuretic peptides and for echocardiogram to assess the elevated LV filling pressure. And you need to exclude other conditions which can mimic the symptoms and signs of heart failure. So these are the guidelines, or you can say the diagnostic criteria. Again, the same we have seen in the definition also, that you need to assess the ejection fraction and the natriuretic peptide and the structural and the functional. So what is the toolbox for confirming the diagnosis? The transthoracic echocardiography is the method of choice for assessment of diastolic dysfunction for both left and right ventricles, and you need to collect the Doppler data, which is equally important. And the parameters assessed are basically the systolic velocities and the diastolic lengthening velocities across the mitral wall. And this is a classic example. What is happening? She is a woman of 75 years of age with dyspnea of NYHA class 2, which is often rubbed off as fatigue or lack of exercise or sedentary lifestyle. But you see the echo, there is a left ventricular hypertrophy, there is a left atrial remodeling with a left atrial volume index of more than 34, and elevated LV filling pressures with a mitral E over ratio of more than 14. But sometimes you tend to miss the patients on resting echocardiogram. You need to do a stress echo, because what will happen is that the patient will complain that when they walk or they climb stairs, they feel breathless. They have palpitations, they sweat, there is activation of sympathetic system. So there you need to do a stress echo to address the problem and to assess the diastolic function related to the exercise, and there are ways and means. And what you need to assess is the left ventricular E and the pulmonary artery pressures and the systolic dysfunctions and stroke volume and cardiac output. And this is the example. You can see the comparison of echocardiography at rest on the left hand side, where the filling pressures are normal, but when the patient is subjected to exercise and you see the echo on the right hand side, the filling pressures have suddenly increased and the E ratio is more than 14. So this patient is having the cardiac decompensation which gets unmasked when he is exercising or exerting. So cardiac magnetic resonance, the CMR, is the very good tool, although it is not commonly done, but it can measure the volumes, the mass and the ejection fraction of both left and the right ventricles. And it's a preferred imaging method to assess myocardial fibrosis. So relaxation of the ventricle you can very well see, and the parameters are tau, the beta and the ECV. These are the three parameters which tells you about the diastolic relaxation and the stiffness constant of the ventricular myocardium. Then you have the gold standard invasive hemodynamic assessment. Obviously, cardiac cath is the gold standard, where you can see the abnormal LV relaxation, filling and diastolic distensibility and diastolic stiffness when you use a cardiac cath. And you can assess the pulmonary capillary wedge pressure. If it is more than 15, this is suggestive of heart failure, and the left ventricular end diastolic pressure of more than 16, which again is suggestive of heart failure. So when we put all the diagnostic modalities together, we have diagnostic scores recommended by the international guideline, and this is the first one, that is the heart failure with preserved diagnostic score. And I will not go into the details, it's available on the websites also. The total sum score is 9, and if somebody is having more than 6, then it is diagnostic of having heart failure with preserved fraction. And the paraclinical variable studies are obesity, hypertension, anybody who is on 2 or more antihypertensive medications, presence of atrial fibrillation, pulmonary hypertension, elderly people, and a filling pressure of LV of more than 9. And this is the second one, which is advocated by European Society of Cardiology, where this is a complex one, and here there are major and minor criteria which assesses the functional, the morphological and the biological markers for heart failures, and you need to do a 2D echocardiogram and the blood test to assess the natriuretic peptides, and the total score is more than 4, then it is confirmatory for 5, then it is confirmatory for heart failure with preserved ejection fraction. So once we have covered the diagnosis based on the symptoms and doing the all the diagnostic modalities, then we come to the management of this condition. Does it differ from the classical or the conventional management of the heart failure? These are the recommendations for patients with preserved ejection fraction, heart failure. Diuretics, as and when it's class 1 recommendation. SGLT2 inhibitor is class 2A. ARNI, that is sacubitril and valsartan combination, is 2B. The spironolactone is 2B, and the ARBs again is 2B. And all these drugs will give you benefit more when the ejection fraction is dipping down and close to 50%. If somebody is having an absolutely normal ejection fraction, the efficacy of these drugs will be not to that tune. So how do you treat? Treat congestion in both the condition, preserved and reduced ejection fraction, diuretics. It will help in alleviating the symptoms and the pulmonary congestion. Then treat the precipitating factor, and in this condition with preserved ejection fraction, manage comorbidities, AF, coronary vascularization, etc., and treat the perpetuating mechanism, whereas the inflammation and fibrosis of myocardium is there in the preserved ejection fraction, and neuroendocrine activation is the main mechanism in reduced ejection fraction. So this is the stepwise approach to the treatment of heart failure with preserved ejection fraction. Don't miss the diagnosis. Before treating, remember to evaluate for the causes of heart failure. categorize the type of heart failure, general treatment recommendations, treatment of BP, fluid overload, diet, weight management, stress, sleep cycle, treat comorbidities aggressively, tailor treatment to phenotypic subtype of heart failure with ejection fraction, which we will see now. And so this is the tailored treatment according to the phenotypic subtype of heart failure with preserved ejection fraction. This is a garden variety where you can have mixed etiologies and there you need to treat the comorbidities. If somebody is having coronary artery disease as the cause, consider PCI or CABG and excessive treat CAD medically if that is not possible. And somebody is having a pulmonary hypertension and the right heart failure, then diuresis, then cardiomems is an invasive technique where you can monitor the pulmonary capillary wedge pressure and the pulmonary arterial pressures. You can use midodrine, which is available commercially if somebody is having hypotension, because it alters with the filling of the right heart and eventually the left heart if the blood pressure is too low. Then atrial fibrillation, obviously cardioversion. If that is not possible, then anticoagulation. Then cardiomyopathy, where there is a hypertrophic cardiomyopathy, then you need to use negative inotropes, preferably the calcium channel blockers, verapamil and diltiazem, and you can use metoprolol or bisoprolol. And vasodilators should be avoided here. You should not reduce the volume of the blood here in this condition. Valvular disease can also present with this condition, and you need to treat that. Then there are conditions with high output, thyrotoxicosis. Sometimes pregnant female we see, they will present with these symptoms. They are hypertensives, they are obese, and they will have symptoms of heart failure. So they are presenting with high output heart failure with preserved ejection fraction. So there we need to treat them with diuretics. And then there are rare causes which we need to see. So stratify based on clinical presentation phenotype, where exercise-induced increased LV filling pressure. There you need to do exercise training and use ACE inhibitor. And there are novel therapies which my cardiologist friend can elaborate upon, that is the interatrial shunt device. Then you have second phenotypic condition, that is volume overload heart failure with where you use MRAs, spironolactone, SGLT2 inhibitors, and RD has a role in this kind of clinical presentation phenotype. And then there is third condition, that is right heart failure, where there is diuresis, midodrine, and drugs to reduce pulmonary hypertension can be used. So these are the therapeutic strategies for different phenotypes of heart failure with preserved ejection fraction. I will not go into the details, but first condition is overweight or obese or metabolic syndrome patient or type 2 diabetes patient. You need to treat lung condition, you need to take care of the chronotropic incompetence, pulmonary hypertension, skeletal muscle weakness, and atrial fibrillation if there is any. And the second condition is the systemic hypertension. Obviously the lung congestion can be treated by ACE and ARBs and calcium channel antagonist. Then chronotropic incompetence can be treated by ACE inhibitor or ARB or even a pacemaker of atria, and the pulmonary hypertension needs to be treated, the skeletal muscle weakness and the atrial fibrillation. Then you have this phenotype, kidney dysfunction, where ultrafiltration should be tried if patient is symptomatic with heart failure, because that will give you a definitive relief. And we see quite often that patients who have chronic kidney disease with a creatinine of 2.5 or 3 or 3.5, they are hypertensive and they are presenting mainly with dyspnea or edema, and they are NYHA 2 or 3 or even sometimes 4. So in that condition, creatinine is not the cutoff, but ultrafiltration may be required to alleviate the symptoms if they are not relieved by medication or other means. Then coronary artery disease, definitive treatment is available and one should try, except for microvascular angina, where you need to manage the patients with maximum medical management. And these are the treatment modalities: ACE inhibitors, ARBs, beta blockers, calcium channel blockers. Digoxin is useful in only those patients who have RV dysfunction for effects on RV inotropy, or maybe where there is AF and you need to control the rate along with that, the pumping power of the heart. Then phosphodiesterase 5 inhibitors, loop diuretics, thiazide diuretics, then aldactone and eplerenone, nitrates. And with all things said, there is a huge gap for the in the management of heart failure with preserved ejection fraction, and future research directions are needed as far as these parameters are concerned, that is the definitions, the screening, the diagnostics and monitoring, the non-medical strategies, the medical therapies, the device management and advanced therapies, the clinical outcomes needs to be improved, the social determinants and the equitable distribution of the therapeutics should be there, and the comorbidities should be reduced and should be better addressed, and future and novel strategies like pharmacological therapies, device therapy, invasive or non-invasive hemodynamic monitoring, telehealth and wearable technologies will help us in long run for management of heart failure, especially with preserved ejection fraction. Thank you very much for your kind attention, and this is the summary that the definition, any heart failure with symptoms with normal ejection fraction or more than 50% is labeled as heart failure with preserved ejection fraction. The transthoracic echo, by and large, along with the blood test of pro-BNP, establishes the diagnosis, and we need to be very cautious in managing the comorbidities and counseling the patient for their overall survival. Thank you very much.
Excellent presentation, Dr. Puneet, and you have very well covered all the topics. So this is the beauty of medicine, something which existed around 20 years back,
yes,
and we were not knowing of there some entity, heart failure with preserved ejection fraction. Now we are talking of it, and now we are treating of it.
So what we see quite often is that anybody who's come with a normal echo, with normal ejection fraction, he's rubbed off that your heart is okay.
So it
even if he's complaining of the symptoms, he's just rubbed off. So this thing should be looked for more aggressively if we have to address, because it carries significant mortality. 35% people still can die in 1 year's time with this condition if they are not taken care of.
So it's very important to diagnose it early and prevent complications. So the same patient with heart failure with preserved ejection fraction later on land into heart failure with reduced ejection fraction. If you don't treat early, you will have a lot of complications.
Yeah, so that is the terminal event. Ultimately, it's going to fail.
So as we are running short of time, we can take 1 or 2 questions only. Otherwise, we will move to next topic.
I have got one question.
Maybe if I can answer.
Tell me, there are 2 practical cases, like a patient with a hypertrophic cardiomyopathy without obstruction comes with a HF. So how will you treat? Number 1. And number 2, another patient with the aortic stenosis, quite significant aortic stenosis, and presenting HF.
The first question is anything which is leading to hypertrophy of the left ventricle needs to be treated. The hypertrophy is not good as we make our biceps, it's not good for heart. That's why we see more and more mortality in marathon runners and the weightlifters, and all those patients, they die of sudden heart death. So that is one part. The heart failure is the second part. So we need to take care, and as we have said that afterload reductors like ACE inhibitors and diuretics, they should not be used if there is, especially if there is obstruction. Otherwise, management of the cause of hypertrophy, whether it's hypertension or anything else, needs to be done. And calcium channel blockers like diltiazem and verapamil, they make a good choice for that. Even beta blocker, because you need to reduce the chronotropy and the inotropy both in that condition.
So would you give diuretics in those patients?
We can use diuretics to alleviate symptoms, but if we reduce the blood volume too much, then the filling is already compromised. It will further aggravate the situation. So we need to be very careful about the use of diuretics in that situation.
That's the problem with diuretics. If you give diuretics,
so that is the balance which one has to strike while treating the patient.
And any comments on entity like isolated right heart failure with preserved ejection fraction? Anything you want to add?
So that in itself is a different entity in total, but we have covered a very small aspect that if there is predominantly right heart failure, then you have to address that, and probably there the role of digoxin has been said, that because right ventricular muscle is much weaker, and if you can just push, it's a passive conduit, if you can just push the blood from the right ventricle, you need to reduce the pulmonary pressures, so you need to use the drugs which cause pulmonary vasodilatation, and you can use some of the inotrope to address that. Otherwise, the treatment like diuretics and they remain same for right heart failure to alleviate the congestive symptoms.
Thank you very much. So we move to the next topic. I invite Dr. Deepak Gupta.
Thank you.
And his topic is state of the art management of heart failure with reduced ejection fraction. We all know it's a very common entity. We see a lot of patients of dilated cardiomyopathy. They are coming in heart failure. So let's learn from him how we should treat those patients.
Good afternoon, everybody. Thank Dr. Binmani and APIs to giving me an opportunity to talk about this topic on the heart failure with reduced ejection fraction. You know, the recent guideline when it came across, I am tried to update my knowledge about the heart failure reduced ejection fraction. The recent guidelines shows the 196 page with 33 tables, 190 recommendation. So it is not the art of state of the art management of the heart failure. To summarize all the guidelines in 18 minutes is basically art of the management. I am just showing in the next 18 minutes how we summarize everything. You know, the heart failure is still, in spite of lot of drugs available in the market and in history, it is still one of the most common cause of the hospital admission, we all know. And you know, the universal definition, stages and classification. We are running behind the ejection fraction, ejection fraction, ejection fraction. You know, the ejection fraction is good for the, in spite of all limitation for the diagnosis of the heart failure, depending upon the ejection fraction, preserve, mid-range, reduce, improve injection fraction, so many classification. In spite of so many limitation of the ejection fraction, still it is used for the classification. Stages wise, you know, the sitting, all, if you consider all the audience in this hall, I must know that 70 to 80%, if you go to this stage, might have stage 1 or stage 2 heart failure in this audience, if you go by this stage. So there is a lot of limitation of all this. Definition, you know the recent update in the definition. LVF is a holy grail in the management of the heart failure is questionable, because after the preserved ejection fraction, you know, the ARNI, SGLT2 inhibitor, diuretics, ACE inhibitor, beta blocker, everything has been used in both conditions. So it is not important for choosing the pharmacy, but it is important for the prognosis and as well as device therapy. Now the management of heart failure is basically reversal of the maladaptive signal. So what happens in the heart failure, you have some adaptive mechanism and later on it becomes the maladaptive. So we focus to treat all this condition to reverse the maladaptation. So everything focus on around this one. Now some focus on the gene that regulate the adaptive and maladaptive process. We have some clinical trials, but challenges remain in the translating all these things into the clinic. You know, the diuretic is still all-time hit in the decreasing the morbidity. You cannot believe that diuretic has started its treatment modalities since long back, from 17 to 18 decades back. And it has been shown that it is the most useful drug, but it decreased the morbidity and trials showed no mortality benefit of the diuretics. So what is the aim in the last 4 decades is to decrease the mortality, reduction in the mortality, cardiovascular, hospital admission and all cause mortality, avoiding the recurrent hospitalization and improve the clinical status. So this is the evolution of this treatment protocols. We all know that from the last 4 decades we have a vasodilator, beta blocker, ICD, CRT, so all evidence based. 2010 we have an ARNI and now 2020 we have a SGLT2. So all this evolution and the true story of this modern medicine is the very, very good evolution. Now these are the total medicine available device, including the device therapy available for the heart failure. So what is the challenge is to receive all these medicine at the timely fashion and the selected group of patient in the recommended dose. Anticoagulant only for those patients who have in the atrial fibrillation, CRT for those patients who have refractory heart failure, ivabradine for those patients who have to select all drugs in the selected group of the patient and give in the proper way. But these are 4 pillars of the heart failure nowadays is the MRA, ARNI, SGLT2 and beta blocker. So we will focus all these four pillar in this trial. This is what is called the quadruple therapy. It's a new standard of care and is a fantastic for. You know the cumulative, if you calculate the cumulative effect of 73% relative reduction of the mortality is so huge. And the study shows that if you combine all four drugs, the relative risk reduction in the mortality is 74% and relative risk of heart failure hospitalization is 85%. So much huge benefit. What is the bonanza of quadruple therapy? Dual therapy, if you start with the beta blocker and ACE inhibitor or ARB versus this quadruple therapy, there is extension of life for the more than 6 years. And in the future, it may be possible to combine all these four drugs in a single tablet. May be possible. ARNI, it is came I think 4 or 5 years back, and it is one of the most successful treatment modalities of the heart failure, replacing the ACE inhibitor or ARB. So there is some clinical pulse that if you are already giving the ACE inhibitor, stop it for the 36 hours and before initiating this ARNI. BNP is not a good marker if you are already giving the ARNI because it inhibits the peptides. Starting dose is a very, the recommended dose is 50 milligram, but you can start with a low dose. You can titrate it in the 1 or 2 weeks and then give a maximum dose. Now, SGLT2 inhibitors is the next blockbuster of the multifaceted drugs. Everyone is talking about the SGLT2 inhibitor in diabetes, heart failure, preserved ejection fraction, reduced ejection fraction is the next blockbuster. But the origin of this flozin, SGLT2 inhibitor, came back from the 1835. It was shown that the apple bark has some property of the flozin which decreases the use for the glucosuric agent. Now, mechanism of the SGLT2 inhibitors is proposed. The basic mechanism is the diuretic-like action, glucosuric, but these are the other benefits, like it is a nephroprotection also. It delays the dialysis. It is also seen that it stimulates the erythropoietin and increase the hemoglobin level, decrease the left ventricular mass, reduce the vascular stiffness. So many pleiotropic effects. It also shift the metabolism in the efficient way. So meta-analysis of the SGLT2 that shows that the reduction risk of cardiovascular death or hospitalization, heart failure is around 33%. What are the contraindication? Type 1 diabetes, lactation, patient on the dialysis, ketoacidosis, and known hypersensitivity is the contraindication. Now, initiating the SGLT2 or switching to ARNI reduce the MRA discontinuity. This is also important. If we add the ACE inhibitor with the MRA discontinuation is very, very high. But if we add the SGLT2 or ARNI, the MRA discontinuation is very, very low. So guideline 4 years back or 5 years back, we have an ACE inhibitor or beta blocker, then I titrate each, add MRA later on, and then you can start the all four drugs simultaneously so that we get the benefit of all these drugs as a mortality benefit. So the current scenario is that from day one, and this is a recommendation also, that day one start the ARNI, beta blocker, MRA and SGLT2. If you start with the low dose, it's okay. Up titrate is all these drugs within 4 weeks, and every drug should be on board in 1 month to get the maximum benefit of this quadruple therapy. When the patient has congestive heart failure or ADHF, acute decompensation of the heart failure, a patient gets admitted in the hospital. You can stop all the drugs. You can give inodilators, dopamines or diuretic, decongest some patient, change it to the oral diuretic, and immediately you can add all these drugs, ARNI, beta blocker, SGLT2. When shifting the patient to the ward or rooms, start all these drugs. So aim is to give all these drugs to get the benefit of mortality benefit of all these drugs as soon as possible and board it in the up titrate in the next few weeks. If you give optimum dose of GDMT, quick start and quick up titration, the data says that you can save the 90,000, 8,000 lives, maximum life saved by the SGLT2. Clinical benefit appear within days. Don't wait that will give the ARNI after 1 month, you will give the MRA after 2 months. So study shows the beta blocker, ARNI and the MRA, SGLT2, the benefit you can start from the very early days. So what is the hesitation? will not start multiple need medicine at one time because of the intolerance. The study shows that you can start at the low dose, monitor the patient. If it is intolerant, you can stop temporarily, again start. So aim is to give all quadruple drugs. But there is no, the RCT as usual. No head-to-head trial that if you start simultaneous or you start the rapid sequencing, no study. So what is take-home message? That optimal approach to initiate each 4 medicine proven to reduce all-cause mortality, break the clinical inertia, treat the heart failure ejection fraction with a sense of urgency of all the drugs. But what is the tragedy? Tragedy that the CHAMP registry shows that only 10 to 25% of the people getting this target dose of the this GDMT agent, and only 1% of the patients were simultaneously treated with this drug. So we are not getting the benefit of all these 4 blockbuster drugs. So what is the barrier? It is the cost. Really, if you give all those 4 drugs in a patient, it costs around 200 or 250 rupees or 300 rupees per day. If you give in the proper dose, recommended dose is around 300, 400 rupees per day, and a lot of cost is the main factor barriering it. Clinical inertia is also one of the responsibility. Preference to the outpatient setting. You want to give in the OPD, but it is better to start in the hospital if the patient is getting admission. And lack of awareness is another thing. What is the major clinical factors? Worsening renal function, low blood pressure, low heart rate. So low heart rate, we hesitate to give beta blocker. Low blood pressure, we hesitate to give ARNI, we hesitate also to give SGLT2, but the SGLT2, very minimal effect on the blood pressure, usually do not have any hypotension too much. Worsening renal function is also one of the hesitation. Less than 30 GFR, the ARNI and SGLT2 both should be not given. Just I have given a humor. मौसी पूछ रही है जया से, अमिताभ से, अमिताभ समझा रहा है कि SGLT2 बहुत अच्छी ड्रग है, मौसी इसे जरूर देना चाहिए. मौसी इज अ डॉक्टर. The guideline ends, the pharma company explaining SGLT2 is very, very good drugs. मौसी पूछती है, हाँ बेटा, क्या क्या साइड इफेक्ट ये भी बता दो जरा. सुने हैं कि एम्पुटेशन भी करवाता है, सुने हैं फॉर्नियर गैंग्रीन भी होता है. अरे मौसी ये सब बहुत रेयर साइड इफेक्ट है, बहुत बेनिफिट है, जरूर देना. Just to put a humor. What is the misconception? If ejection fraction recover, don't stop the drug. Continue. But till how much day, we don't know. There is no guidelines. But if the ejection fraction improve with all these drugs, continue this drug for the few years. Another misconception is the marginal blood pressure. If you had 110 by 80, 110 by 70, usually avoid to give all these drugs. Don't do it. Give in a low dose, see the patient the next week, up-titrate it, add another drugs, and put all drugs in the 3 to 4 weeks. Heart failure management in the renal dialysis patient or nephro patient is a really challenge. As previous speaker also told, this ultrafiltration is one of the options. Beta blocker you can use safely. Halogen nitrate combination is also useful. But trial level evidence is needed for the ARNI and SGLT2. Recently some trials are going on, or some trials are given the benefit of all these drugs. MRA should be avoided. Modification of dialysis in the heart patient. Nocturnal dialysis is also an option. Cool dialysis, ultrafiltration, or if a patient is hypotension during dialysis, give amiodarone, or AV fistula if you give in the high output, clipping of the AV fistula is another option. Now, precipitating cause, one of the major factor when the patient get admitted, identify the precipitating factor and comorbidity and treat all these conditions, like if the patient in the AF with the fast ventricular rate, control the rate. Infection usually precipitate the heart failure, treat the infection. Rule out the any ischemia is responsible for the precipitating cause. Alcohol, anemia is very, very important cause. Thyrotoxicosis, embolism is also, we missed usually the diagnosis. And also the sometimes NSAID. This is the new drugs, this is the soluble guanylate cyclase stimulator. From the neurohormonal activation, you are now shifting, the researchers are shifting to search for more drug which is acting directly in the myocardium. See, this is FDA approved, but symptomatic hypertension and syncope is one of the major common factors. Another drug, new drug is the cardiac myosin activator. It improved the contractility, but improved, approved by the FDA. Device therapy, all know that the CRT and the AICD, I am not going to the detail, but it is advanced heart failure. CRT is one of the major factors that influence the life. These are the recommendations that patient with heart failure on GDMT for more than 3 months and more than 40 days of the acute MI or with a special indication for pacing. These are basic criteria for putting the device therapy CRT when you have an LBB and QRS duration is more. Another one is the LV, left ventricular assist device. The 2-year survival rate is 80% in the recent trial with the newer generation and approaching the cardiac transplantation. Cardiac transplantation is the ultimate solution for the heart failure patient wherein they refracted to the drugs. New transporter systems has arrived, and these are 2 pictures I am showing. The one is surviving more than 32 years. Another one is the lady which is surviving, celebrating his second transplant. One transplant failed, and later on she went to the second transplant, and she is celebrating his 40 years. This is the youngest transplant patient, looks like this one after 24 years. So what is the status of the transplant in India? We have reached in the past 5 decades. The first successful heart transplantation in India was done in the AIIMS, New Delhi in the August 1984. The patient survived for 14 years. The longest survival is AIIMS is 21 years and is still surviving. So till now we had 1,113 heart transplantation, 101 lung transplantation, but in corona, the lung transplantation incidence has increased a lot. Some concept is that the simultaneous heart and kidney transplant is also there. And last 4 decades, last 4 years, we have the increasing incidence of both transplantations simultaneously. There is some therapy because the FDA approved therapy, and this is the this is the CCD, cardiac contraction modalities, when we give a special energy to the absolute period of the myocardium and the septum so that the contraction can be increased. Baroreceptor activation is also helpful to improve the parasympathetic activity. And another one, when the functional MR, then we have a edge-to-edge repair of the mitral valve by transcutaneous method. These are the investigational therapy, like the decreasing the size of the myocardium by reconstruction surgery, stimulation of the phrenic nerve, especially when the patient is sleep apnea. This is the interatrial shunt, when the pressure of the left atria can be decreased by putting a shunt across the interatrial septum. Another one, in the acute heart failure, we have a splanchnic nerve stimulation so that the blood can be diverted to the splanchnic vessels and the acute congestion can be relieved. What are the future of the target beyond the neurohormonal? The new targets on the direct on the myocardium, prevent the inflammation at the molecular levels. Genomic and heart failure are another future direction of the heart failure treatment. And the finding a needle in the hair stick. There is a proteomics in the heart failure. This is the last my slide. We are searching for more molecule, going to the more molecule level, mitochondrial level, to increase the, put in a more therapy for the heart failure. Thank you for my attention. I think I have completed my talk in the less than 18 years. Any question?
Is there any question? Dr. Gupta,
Yeah.
I have got a question. If there any audience, any question? See, very often when we treat these HFrEF patients, many of the patients there, particularly I'll tell you, yesterday I have seen a patient. His blood pressure is 100/84. And what kind of drug I will give to this patient? 100/84. And
100/84.
Ejection fraction is less than 20%.
Pardon?
Less than 20%.
Ejection fraction less than 20% and heart rate, blood pressure 100. It is a very, very common, and I have told that don't fear about the blood pressure. Start your drug. If there is no other contraindication, if the renal function is okay, suppose, start your drug, choosing if the heart rate is also more than 70, 80, beta blocker, carvedilol, bisoprolol, metoprolol. 3 recommended drugs, proven drugs for the heart failure. But the carvedilol has more vasodilatory effect. You can start with the metoprolol, with a very less blood pressure lowering effect. Metoprolol you can start. You can start also the dapagliflozin or empagliflozin because the blood pressure lowering effect is very, very less. ARNI, MRA. MRA is also blood pressure lowering effect is very, very less. Only ARNI is concerned. But you can give a very low dose of the ARNI in this patient also. Ask the patient to check the blood pressure morning, evening. If the blood pressure fall more than 20%, you can stop temporarily. Next time you again add. The idea is to put all these drugs to get the benefit, mortality benefit. In spite of low blood pressure, you can add MRA, you can add beta blocker, you can add the dapagliflozin.
Any question from, please. Sir, please use the mic.
Just a comment on what you said. That in Indian patients, we find it difficult to switch to put ARNI in full doses, 200 BD. It becomes really difficult. Majority of them will respond with 100 BD and will not tolerate beyond that, although the maximal effect is with 200 BD. So that resistance is at both the patients and at the physician end also.
Yeah, 200 BD is not possible to, even after the 1 month.
Yeah.
It is difficult to put the 200 BD. Cost is a different matter. But suppose the patient is having blood pressure of 160 by 100 or 160 by 110, you can add it to get a benefit of the maximum dose. But if your blood pressure is 110 or 120, the Indian patient don't tolerate too much dose in every drugs. So this is the fact.
Which molecule you prefer in, which SGLT2 molecule you prefer and what should be the doses?
Yeah.
How long?
DAPA and IMPA, only two drugs has been extensively studies. Another drugs also studies. The trial has terminated. Why? Because of the financial reason. Benefit has shown, but first time the trial has stopped because of some financial reason. But extensively studies are DAPA and IMPA. DAPA has, the more data, dapagliflozin has a more data. IMPA is also very, very useful drugs. So now most of the physicians are depending upon the DAPA heart failure trials. So they are using more DAPA, 10 milligram DAPA. But if the patient is diabetic, also IMPA is also effective. And IMPA was the first drug which has shown the benefit before the DAPA. So both are the drugs, head-to-head trials, I don't think it is available. But DAPA is more preferred for the physician, and the IMPA, if you are diabetic, you can start DAPA. You can start with the 10 milligram. Okay. No need of up titration. But in clinical practice, we fear of the blood pressure, we fear of cost. Many physicians start 5 milligram also. But it is a better idea to put on a 10 gram, see the effect.
How long?
Till you have to treat the heart failure.
Any risk of hypoglycemia? Treat long.
Hypoglycemia, I don't think the hypoglycemia effect is any concern too much. Only concern is the development of UTI, especially when the patient is old, female, diabetic. So be careful, ask to clear the genitalia every time. If there is any suspicion, must contact. Mycotic infection is also common.
Thank you.
So any comments on in elderly patients we use MRA and hyponatremia is very frequent. So at what level of sodium you would like to stop this MRA?
I know the MRA is basically to prevent the hyperkalemia. Sodium is not important for MRA. Sodium is important for the, the furosemide or tosemide. But when you are giving the MRA, I don't think it's causing too much hyponatremia or concerned. Only concern is the hyperkalemia, especially when we are adding the ACE inhibitor. If we are adding the SGLT2 or ARNI, even the discontinuation MRA has decreased a lot. And MRA is the only drugs you can start later on. Because immediate effect of the MRA is not too much. The trial has shown the benefit from the 1 day. The MRA benefit is the diuretic plus prevention of fibrosis, which will take that time. And I don't think sodium is too much concern shown in the different trials. Thank you.
Thank you, sir.
Thank you.
Thank you very much. Let's have an applause. What they have been giving them. The next speaker is Dr. Virmani. He is a well-known diabetologist and cardiologist of Jamshedpur, and he is going to speak on management of severe anemia and heart failure. Dr. Virmani.
Honorable chairpersons and dear friends, can I have the slides, please? Okay. This is the biodata. A patient comes to you in your clinic with history of chest pain. You do an ECG and there are certain ST wave changes which are non-specific in nature. You refer him to the cardiologist. Dr. Deepak Gupta does an angiography. Angiography is normal. And he sends back the patient to you, normal angio. You feel happy, but the patient keeps on coming back to you with chest pain. Now, this is a diagnostic dilemma. Should we label the patient as a cardiac neurotic, or should we suspect microvascular angina? The only disclosure I have that I am not an interventional cardiologist, but I know and I am sure that what information I want from the cardiologist, I will definitely ask him. Now, 50% of the stable angina patients who undergo diagnostic coronary angiography and 10 to 15% of those presenting with acute coronary syndromes have a normal or near normal coronary arteries. Now, this is called angina with normal coronary arteries, and this has been a continuous dilemma right since 73 when it was labeled as cardiac syndrome X, and in 1985 as microvascular angina. It has also been called INOCA and MINOCA, that is ischemia with non-obstructive coronary arteries and myocardial infarction with non-obstructive coronary arteries. It is indeed a black box, and can we open the black box to see what is happening? Is there a coronary microvascular dysfunction, whether it is abnormal cardiac pain sensitivity, endothelial dysfunction, or perhaps a combination of these two? So what I am going to do in the next couple of minutes is to discuss the coronary microcirculation, classify the disease, pathophysiology, clinical presentation, assessment, and management. When we talk of coronary artery disease, it means that there is a stenosis, one or more stenosis in the epicardial arteries, which is more than 50% as compared to the, referred to the on the angiographic images as compared to the adjacent vessels. But it does not acknowledge the flow beyond these lesions in the black box or so-called microcirculation. This is what the angiography, the cardiologist sees, and what he does not see is this. So you can imagine the cardiologist sees only 5% of the coronary tree, only 5%. And based on that, we make a diagnosis of either a cardiac neurosis or normal heart. Now, if you look at the circulation, I will not go into details, just remember the macrocirculation, epicardial arteries of more than 400 microns, which the cardiologist is looking at, and the microcirculation, small arteries going down from less than 400 to even less than 100. What I want you to here remember is two things. There is something called fractional flow reserve, and that tells us something about the macrocirculation. And there is something called the coronary flow reserve, which talks of the total coronary flow reserve. When you look at the microcirculation, it is the index of microvascular resistance, which is very difficult to measure. So what you have to do, you have to remember only two things, the FFR and the coronary flow result. Now, on one side we have atherosclerotic disease in the epicardial arteries, on the other side microvascular dysfunction, in between is vasospastic disease, and that is what leads to ischemic chest pain. So obstructive, vasospasm, microvascular dysfunction, and they all are overlapping in the myocardial substrate. So what are the clinical implications? It can lead to myocardial ischemia and often mimic obstructive coronary artery disease. There is basically an increase in the coronary microvascular resistance giving to the symptoms. It was earlier called cardiac syndrome X. But remember, it can also occur in the context of other cardiac diseases and as well as in association with obstructive coronary artery disease. And there is now a growing interest in the documentation of coronary microvascular dysfunction in the context of established coronary artery disease, epicardial obstruction. Classified: type 1, absence of myocardial diseases and obstructive coronary artery disease, that is true microvascular dysfunction. Risk factors: microvascular angina, pathophysiology, basically endothelial dysfunction and smooth muscle cell dysfunction. Then we have those associated with common myocardial diseases like hypertrophic cardiomyopathy, dilated amyloidosis, etc. And then we have the classical obstructive CAD, and then we have iatrogenic related, maybe rupture after the PCI or CABG. The first one, type 1, is primary and these are secondary. Clinical presentation: primary microvascular angina, stable if the dominant effort angina, unstable if acute rest angina. And remember, there is a gender variation, higher prevalence in females. So we are more likely to miss it and diagnose it as cardiac neurosis. Now, the clinical pearl here is when the patient presents with chest pain, this chest pain is longer lasting and there is slower resolution with nitrates. So if you see a patient where the chest pain is lasting for a longer time as compared to the usual clinical classical angina and the resolution is slower as with nitrates, suspect microvascular angina. These are the classical pictures: typical angina, normal ECG, normal coronary angiogram. Now, but before we go to microvascular angina, it is mandatory to rule out vasospastic angina. So you look at the ECG, you look at the classical symptoms, and if there are matching, yes, possibly vasospastic angina. If not matching, vasospastic angina, unlikely. But this is a clinical scenario that you are looking at. So basically, we must know that we have to do a functional evaluation with an acetylcholine provocational test, and we have to do a morphological evaluation with various invasive and non-invasive tests. This is the classic acetylcholine test. You see a constriction here, and you see after giving isosorbate, the constriction disappears. This is a classic case of vasospastic angina. Now, there are certain limitations of acetylcholine provocation test. It has got a high sensitivity and specificity, but then again, compared to the coronary angiography, there are certain problems. You are using contrast media, so it can have renal adverse effects, radiation exposure, bronchial asthma can be precipitated, patient can have complications like VT, cardiac tamponade and shock. So majority of the interventional cardiologists don't want to touch this area. For them, just doing an angiography is their bread, butter and jam. They are happy with that. That is the problem. But in good centers and in good hands, it is a very, it is a safe method and it can be performed carefully in good centers. Now, if you look at the difference, how the patient presents, if there is vasospastic angina, there is first of all perfusion heterogeneity, then metabolic alteration, then diastolic function, regional dysenergy, ECG changes, and patient comes to you with angina. On the other hand, if the patient is having microvascular angina, there are initial ECG changes, angina, and then it leads to perfusion heterogeneity. So what are the investigations? We have the exercise of dopamine echo, we have the transthoracic Doppler echo, and the acetylcholine and adenosine test to find out the vasospasm and hyperemia. Now, another clinical pearl, when you are doing echo, if the patient is having epicardial coronary artery disease, there will be regional wall motion abnormalities, and the distribution of myocardial ischemia is usually diffuse. In microvascular angina, the distribution of myocardial ischemia is patchy. There are no regional wall motion abnormalities. So the absence of regional wall motion abnormalities again gives you a hint that this is microvascular angina. And this is basically you looking at impaired vasodilatation and impaired vasoconstriction with the various tests. So what are the assessment morphological evaluations you are going to do? The most important is the invasive one, and that is using the Doppler wire coupled with a pressure thermodilation device to measure both the coronary blood flow and the coronary vascular resistance. And then we have the non-invasive investment with the positron emission tomography, and the CMR, the cardiovascular MR, is also coming up. Now, this is the classical one. You see a defect on the myocardial perfusion, but here there is a abnormal global myocardial perfusion, and the coronary angiography was normal. So again, I stress on the fact, while doing an echo, if there is regional wall motion abnormality, is coronary obstructive disease. If there is no RWMA, then look for microvascular angina. Now, I talked about two things that I told you to remember initially, the fractional flow reserve and the coronary flow reserve. The fractional flow reserve is specific for epicardial disease. The cutoff is 0.8, which means anything less than 0.8 is inducible ischemia, more than 0.8 is no inducible ischemia. And the cutoff for the coronary flow reserve is approximately 2, that is, which is a borderline, so they describe the take cutoff as 2. So how do you diagnose? If the FFR is less than 0.8, it is inducible ischemia, so it is flow limiting stenosis. Then you look at the coronary flow reserve. If it is normal more than 2, it is preserved microvascular function, and if it is less than 2, it is coronary microvascular disease. On the other hand, if the FFR is more than 0.8, it is non-flow limiting stenosis. Again, you look at CFR, if it is more than 2, again preserved microvascular function, and if it is less than 2, it is non-flow limiting, it is coronary microvascular disease. Both are non. And this is the ultimate algorithm, and you can then diagnose epicardial coronary artery disease, microvascular angina, or both microvascular plus vasospastic angina, or no cardiac chest pain, patient is normal. So it's a very good way to do it, and the main thing is to look at the CFR after looking at the FFR. Medical treatment, all of you know, short-acting nitrates, beta blockers, calcium channel blockers. Now, long-acting nitrates have very limited efficacy in the microcoronary circulation. Other drugs, ranolazine, avabradine, nicorandil, trimetazidine. I won't go into details, all of you know where to use when. There are additional drugs which are needed in these patients, like the RAS blockers, statins, xanthins, and estrogens, etc. Then we have non-pharmacological treatments like spinal cord stimulation and enhanced external counterpulsation. Then, of course, to give you the final message, which drugs this patient should be optimally taking to prevent recurrent angina: aspirin and statins, class 1B evidence, beta blockers 1B, calcium antagonist 1B. AC inhibitors or nicorandil 2B, B, and xanthin or neurostimulatory techniques, again class 2B level B. So therapeutic approach, the specific goal in the treatment of stable microvascular angina patients is to decrease the anginal symptoms, improve the quality of life. And after having used all this, the main aim is that you must have a pathophysiological approach in the treatment. And what is that? You should try to affect myocardial oxygen demand, microvascular spasm, or abnormal vasodilatation, or perhaps all the three together. That should be your aim, ultimate aim.
Now this is a recent article published in the Journal of American Cardiology this year only, about a month back, and look what they are saying. There is a paradigm shift. Non-epicardial coronary causes are more prevalent than flow-limiting stenosis, and we never knew this. We always thought angio is normal, forget. Assessment of ischemia that do not delineate abnormal coronary angiographic findings should not necessarily shift diagnostic and therapeutic considerations to non-cardiac causes of angina, but rather look at microvascular angina. That is very important. It is very important before labeling the person as cardiac neurosis or looking for non-cardiac causes, do a functional assessment of the coronary circulation. And such additional testings can be done wherever needed. Now, a conservative approach to management, you need to have a non-invasive approach, then lifestyle interventions, goal-directed, multifaceted medical therapy, and this is all evidence-based and can be used. So the key messages that I want to give you today, friends, is angina with evidence of stress-induced myocardial ischemia, but normal coronary angiogram is called microvascular angina. Less than 2 on adenosine-induced hyperemia. So hyperemia, you are inducing with adenosine. If it is less than 2, it is microvascular dysfunction. There is no spasm. You have to rule out vasospasm on acetyl provocation before coming to that diagnosis. Exclude out other causes of the cardiac diseases that I talked about, like cardiomyopathies, amyloidosis, and etc. Underlying pathophysiology is heterogeneous, so non-uniform response to different diagnostic tests and therapeutic approaches. Existing guidelines focus on symptom management, and current treatment is reassurance. The treatment. This appears to be insufficient because the ischemia-related events are going to be recur again and again, and the patient is going to come to you again and again. So it is of the utmost importance that the management of this condition is basically patient-centered and focused on the use of adequate anti-anginal medications and on the modification of lifestyle and risk factors. Thank you for a patient hearing.
Excellent presentation, Dr. Virmani. It's actually whenever a patient comes to us with chest pain and he has positive stress test, the only way to rule out is to do an angiogram. So once we do an angiogram, then we are left with 2 entities. When it's a normal angiogram, then either it's a non-cardiac chest pain or it's a microvascular angina. So this is the usual common practice. But by your lecture, we must understand that this entity also exists. Something like what we have seen, heart failure with preserved ejection fraction. Something like that. So
see, that is why I said there is a paradigm shift in thinking. We should not remain static. Medicine is advancing rapidly, and we should be able to change ourselves to new learnings that are coming up. Now, if your angio is normal, you cannot be guaranteed that there is no cardiac problem. Please note this important fact. If you have to do a functional and a morphological evaluation of the microcirculation before labeling the person normally as far as the cardiac thing is concerned. That is an important thing, and that is why I said okay, this is the information I want from the interventional cardiologist. If your angio is normal, I want to know the FFR, the CFR. Have you gone for a acetylcholine provocation test? Have you ruled out vasospastic angina?
see again,
And
cost.
then only then we will think of non-cardiac causes.
Yeah, cost becomes a constraint, and again the complication of the procedures by giving acetylcholine, again that becomes a constraint. Ultimately, we are left with the same medicines. If it's a normal coronary, also we have to give nitrate, we have to give beta blockers, we have to give nicorandil. So at the end of the day, we have the same medicines, whether it's a vasospastic with normal coronary or it's just a normal coronary.
You are right. If the angio is normal and you write the same anti-anginal medicines, one of your colleagues is going to get up and say, normal hai, kaise dawai de di aapko? Now let me tell you a small story. It's a wonderful story. I was giving a talk in Delhi to some of the interventional cardiologists. So I asked them, how many of you sitting here think that you have placed an unnecessary stent? Not a single hand rose. And then I asked them, how many of you think your colleague has put in an unnecessary stent? 40%. So that is happening in the world of cardiology. So we have to now change. You must learn and listen new things now.
But from our side, we want to say that we do angiogram only when it is needed.
Well,
Please believe us.
I'm not blaming you. Angiography is a must to rule out obstructive coronary artery disease. I'm not snatching your bread and butter. I'm giving you that bread and butter, but I'm asking you to do more and give me more information. So I'm giving you jam also along with bread and butter. Don't worry.
Okay, thank you, sir. Lot of interactions. Sir, please wait. Dr. Virmani, sir, please wait. May I request other speakers to please join on the dais? Dr. Puneet Saxena and Dr. Deepak Gupta. See, this is the advantage of arranging such conferences and CMEs. We learn and we relearn and again we relearn so many new things and we interact with each other. So big hand to all the speakers. A wonderful talk and wonderful thing. Dr. Deepak Gupta is very happy. May I request the chairpersons to please hand over the memento to our speakers?
He is happy because he has accepted the jam also.
Oh, he will speak. During lunchtime, I know Dr. Deepak has got a lot to clarify. So, the first memento to Dr. Sumit Saxena. Next to Dr. Deepak Gupta. Dr. Deepak Gupta. And to our very own Dr. A.K. Virmani. May I request?
Yes, in May, non-specific ST changes.
May I request the chairpersons, speakers to please hand over the memento to our chairpersons. We start with Dr. Sumit Saxena to please hand over memento to our Madam Master.
Dr. Das, come here.
Please come at the center of the stage.
Dr. Das.
Dr. Das, please join them. Dr. Deepak Gupta to hand over memento to Dr. N.K. Das. And Dr. Anil Virmani to Dr. Abhay Krishna. So thank you so much. Wonderful session, good interaction. Sir, Dr. Virmani, they are requesting for group photo. Then I think I can also join. Thank you, sir. Dr. Abhay Krishna to please help Madam Master. Thank you. Well, we are coming to the end of the session just before lunch, and we are delighted to have Dr. Jyotimar Paul standing between us and the lunch. So may I request the chairpersons for this session, Dr. R.K. Sinha and Dr. Dilip Kumar, to please come on the dais. And I would also request our speaker all the way from Calcutta, Dr. Jyotimar Paul, to please join on the dais. Dr. R.K. Sinha, sir. Very interesting topic Dr. Paul has to deliver today. Challenges in examination of an elderly. I know it is of interest for all of us. Chairpersons, all yours, Dr. Dilip sir. Thank you.
This is the last session of the before lunch. Everybody worried for taking lunch and
Everybody hungry.
thirsty even. I am delighted to chair the session because Professor Dr. Bhola Mahato, an eminent physician of Jharkhand, Bihar and Bengal, known to everybody who is very senior. Dr. Professor Bhola Mahato, born in a big family in 1927 in Begusarai. He was a very energetic and curious since his childhood. His early education was in Begusarai and shifted to Science College, Patna for doing the intermediate examination. After doing the intermediate examination, he got his admission in Science College. And later on he chosen for as a medical student in the Prince of Wales Medical College, Patna. Now it is known as PMCH. After that he went to Calcutta and he did his DTMH course. And in 1951, he did his MBBS examination and 1957 he did his DTMH. He went to England and he did his MRCP in 1960. After returning from that, he joined the Bihar State Health Services and living here and there. I do not know the full detail. He joined as a registrar medicine in RMCH. He remained there for 3-4 years and in 68 he was transferred to MGM Medical College as a lecturer. At that time there was no assistant professorship like that. Because there was no professor of medicine at that time, he became the head of the department, the main head of the department since that till then. I have not work experience under him. Professor Dr. R.K. Sinha, yes, he was there. I joined later on. He remained head of the department till his retirement and became professor at the age of 58. He was a very academic person, very academician, loving to everybody, and was a very keen interest in examining the patient very thoroughly. Most of my friends who are close to me and senior persons, they have seen his prescription, how much intricate in writing, the full detail. The full page was written with so many good words that we are not able to do all these things. In 2010, he retired. He continued his private practice even after retirement till 2010, sorry. He retired earlier, but he private practice till 2010. He used to give services to the patients coming from the West Bengal, Bihar, Odisha and Jharkhand for the difficult illnesses. He was very truthful from very heart, and he always supported his patient emotionally and financially. Yes, we know it. In his opinion, detailed history taking was the key to each of the diagnosis, very intricate in that matter. But sad, he died on 25th September 2018, very peacefully. He was the founder member of Society for Die with Dignity. May God bless him. He was associated with API with keen interest. He has got so many intricated and so many disputes with the API, but he always fought, and he fought with the cause. There are so many good memories with him because he was very, very casual with coming in all our CME and all our meetings, very used to come. He always used to come with his wife sitting far behind, and he was a very keen interest taking all the CMEs very interestingly. God bless him. With few words, I ask my friend Dr. Jyoti Paul, who is the Dean SCP Kolkata, to challenge for the examination of elderly. अभी बोल दे.
Slides. Please.
The topic of the day is challenging the examination of elderly. You know all, examination of patient is difficult, but to examination of elderly person is very difficult. You have to examine very thoroughly. You may miss so many things which you are not expecting. We have to see from head to no tail. Everything we have to see very meticulously. It's the financial burden, it's the memory, apart from this diabetes, hypertension, cardiovascular disease, renal disease, but the chances of falling, financial, so many things we have to cut. And this is a very tedious task to examine a patient of elderly. Half of the patient, if you are seeing the hospital, they are filled with the 65 years of age and like that. Because of the aging is now more and more. With few words, I hand over the mic to Dr. Jyoti Paul, who is Dean SCP Calcutta. No needs introduction, you can see on the view box.
Thank you, respected chairperson, for your nice introduction. And I am really honored to deliver oration in memory of great physician Dr. Bholanath Mahato. But on the other hand, as I am between lunch and my speech, so what should be my role? Stimulate appetite or destimulate? The subject may be so boring, it can decrease your appetite. Anyhow, but as we are advancing age, we everybody, and geriatric population is becoming a I will not say it is a burden. It is it can be asset to our population. So how to approach to a geriatric patient, how we can give the best care to the geriatric patient, it should be the bread and butter in the coming days physicians. Let us see how we can, what we do and what we do not do, and what we will do from the tomorrow's clinical practice. In the famous movie Ram Teri Ganga Maili, the famous director Raj Kapoor is nicely he sketched the flow of holy river Ganga, how it flows from Himalaya to Sagar and become polluted as it flows down. He compared with the life of a young innocent girl from the Himalaya, and what happens we everybody know. Same thing happens in our life. As age advances, so many disabilities and disease accumulated in our body and become very difficult, complex. We become complex, and even the physicians often miss the diagnosis, cannot give the best care. We often have the increased morbidity and mortality and become the social burden also. So, in the next two index cases, through two real cases, we try to understand how we can assess a geriatric patient, whether it is same like a younger counterpart, is a young hypertensive has came, you measure the BP, give the drug, or it is something else. A 70 years old man came to your clinic with incidence of 2 fall in last 1 month. Remember the word 2 fall in last 1 month. Both fall was in the one in the bedroom, one in the garden, in the daytime, not in the night time. Both was unprovoked, vision was alright, no hearing abnormality. Patient was not any important significant drug like hypertension or diabetes, and before the fall there is no history of syncope, dizziness, confusion, memory loss, convulsion. On continued history, it is seen that patient has a osteoarthritis and can but walk without support. He has no foot deformity, knee or musculoskeletal deformity that can aggravate the fall. No past history of stroke, that means the weakness. Only patient have some low grade fever and mild cough for last 1 month. And that elderly basically had no caregiver, he stay alone in the home, but he can manage his household and basic activity like including shopping and gardening and others. He is retired but getting a good amount of pension. So economically more or less the old person is okay. On physical examination, patient was mildly lethargic, mild confusion, no history of polypharmacy, pulse blood pressure was normal, no postural hypotension, no anemia. Vision, hearing was normal, but patient has last 1 month history of the urge incontinence. On systemic examination, it was found that patient has crepitation in the left lung base. And regarding the extrinsic and situational factor, I told that patient's household condition was more or less okay, room lighting was okay, floor was not slippery, garden was not uneven, and he was habituated to work in the garden during gardening. And medication view, I have told there is no history of polypharmacy, only he used to take omeprazole, some inhaler SOS and some analgesic for the osteoarthritis knee joint. So no basically no drug induced case found in this case. On investigation, patient creatinine was 1.7, high significantly, patient have CKD, patient has anemia, patient have diastolic dysfunction in echo, mild cerebral atrophy, but you see in X-ray there is a consolidation in the left lung base. So that means this patient presented with fall, but background disease, as a background disease, patient have left basal pneumonia. Case number 2, 84 years female, consulted a doctor for the hypertension, 2 drug was given, antihypertensive, BP not controlled. What we basically do, we increase the dose. That thing the doctor has done. Again BP not controlled, again the 3rd drug was added, again BP not controlled, the dose of the 3rd drug was increased, but on a fine morning, patient developed dizziness, fall in the ground and develop hip fracture. This old lady also have caregiver in his home and stay with the son and earn adequately. So these are the 2 index cases. Basically,
patient presented with fall, but there is some other background disease. So fall is often considered as an aging procedure. तो मेरा घर में old lady है वो तो हमेशा fall हो जाता है. But fall is a very important. This is the learning of these two cases. So how we should approach to elderly when we will come to you with significant or non-significant history or some of the findings found on the clinical examination. So why it is a challenge to diagnosis in an elderly? Because elderly are often have a multiple pathology or multiple comorbidity. What our standard teaching, what we learn from our teachers used to told that if the person come with multiple symptoms, try to explain by a single pathology. This is true for the younger counterpart. But in an older counterpart, if you try to put a single pathology, you will go away from the diagnosis. So in a younger counterpart, multiple symptom, single pathology is the usual, but in the elderly, multiple pathology is the usual. And delayed presentation due to the disorder or dysfunction of the immune system, delayed presentation, atypical presentation, and even the abrupt declining of the aging process. Abrupt, patient has a gradually patient his memory is declining. Suddenly patient appeared to you, relative came with his father that the memory suddenly has dropped. So abrupt declining of any system, these are the challenges in elderly patient when we are encountering. And also the defect in the sensory system. Sensory system means hearing, vision and the peripheral sensory system. These defects often create confusion, difficulty in assessing a elderly person. So these are the challenge to us, how we can overcome this challenge. So when you are encountering in an elderly person, there is a fourth domain. In younger patient, there is a only single domain is important, there is a physical assessment. But here, there is a fourth domain. One is the physical assessment, one is the psychological assessment, one is the functional assessment, and is the social assessment. So all four assessment you have to do in an elderly patient to have a complete diagnosis, and this diagnosis is very important for giving the perfect management. And I told difficulty start with the communication, because there are the 7 Ds for which we physicians have the difficulty, have the challenges in facing an elderly patient. One is the deafness, dysphagia, dysarthria, dysphonia, dementia, delirium and depression. So 7 D is a challenge to a physician for assessing an elderly patients. So physical assessment. So I told first is the physical assessment. What is the challenges? Because physical assessment, it should be very appropriate and thorough examination, because this may be possible. The elderly patient for the first time after long period has visited the doctor's clinic. So whenever you got the opportunity, you examine the patient thoroughly, and patient's disability and cognitive defect, patient hearing defect, patient vision defect may be challenged to you to get the proper history. When in the Hachishyan, in the first chapter, that is a very nice chapter, what information you can get when the patient is entering from your chamber. So your first impression start when the patient is entering your chamber, including you observe his walking, you observe his hair, but you will get so many information when the patient is entering. So your process of examination will start observing the patient, how he is entering to his chamber, how he is sitting to his chamber, how he is communicating with you. This is a very important clue of the physician can gather so many important information just simply observing the entry or the way of entry to your clinic. So history taking, one important issue you have to remember, the elderly patient, don't try to stop the patient, because sometimes patient we commonly the patient is very talkative, give a long detailed history, but do not ignore any history. Suppose patient of angina, frequently the elderly patient give more history of his constipation. Even it to you may be relevant, but not to ignore, because that constipation may be the symptom of CA descending colon. So You don't ignore any symptom, give importance to all symptoms. Sometimes you give the leading question and try to what are the most number 1, number 2, number 3, number 4 symptom as per the importance. That is your challenge to categorize the symptoms as per the challenges. And you have to differentiate from the new acute illness to the background disability. What are the background disability? Background disability may be vision problem, hearing problem or memory problem, but what is the acute problem now? On the top of the dementia, patient can present with the delirium. So acute illness versus the background disability, both are important when you are planning for the treatment. History of comorbidity, very important. Patient usually elderly have multiple comorbidity, and one comorbidity altered the presentation of the other. If the patient have diabetes, the chest pain may not be typical or may not patient can feel. There may be atypical presentation of angina without chest pain. Patient can come to you with only palpitation or some distress after taking food, or maybe some more atypical presentation due to presence of diabetes, or the investigation. If the patient have CKD, if you try to do the try to investigate or diagnose the ACS by TROP-T, it can be falsely positive. So presence of comorbidity knowledge is very important before planning the investigation and diagnosis. So relevant domains of the history, these are the relevant domains: family history, social history, functional history, very important, because we want to give the good life. Personal history, immunization history, mobility history, daily activities, support, social intervention, occupation. These are the relevant domain of the history for every elderly you should take. Drug history, my previous speaker was talking about the drug history, polypharmacy, very important. Polypharmacy, drug-drug interaction, adverse effect, difficulty, because in an elderly patient, regarding the one study was done, 30% of the hospital admission was basically due to the adverse reaction of the drugs that mimics some disease. Suppose the hyponatremia, very common we get in the emergency, patient on diuretics in summertime came with a confusional state and diagnosed as a hyponatremia. This is basically the drug effect. And prescription cascade. Patient was put on amlodipine, developed pedal edema. We see frequently the physicians give some diuretics and patient develop hyponatremia. So this is the prescription cascade that lead to more complication, more presentation like some viral or bacterial illness or some other pathologies. But basically, if you omit the drug or change the drug, you can get the relief and can reduce the number of hospital admission of that elderly. Comorbidities can or drug can alter the symptoms. Sometimes one I was telling, patient have the osteoarthritis, patient have limited mobility. So possibly patient has not experienced the exertional angina. So that there will not be exertional angina will not be presented due to the presence of osteoarthritis. Or diuretics, patient present to the urinary incontinence. So if you take the history, you can get only the diuretics has responsible for the urinary incontinence. So rather than going for any prostate surgery and other, just changing the drug, you can get the remedies. Beta blocker, autonomic neuropathy, you know, during when there will be blood loss, there will be tachycardia. But if the patient have autonomic neuropathy due to the aging process or due to the diabetes, the required or expected tachycardia may not be present. So one physician have to be very alert, because we try to diagnose the blood loss by the blood pressure, follow-up blood pressure and rise of pulse rate. But due to the autonomic neuropathy, due to the aging, this may not be presented. So this knowledge we should have when we are dealing a geriatric patient. Systemic examination, there is a challenge. One is the nutritional assessment, because elderly often suffer from undernutrition or overnutrition, both macro and micronutrient deficiency. Remember, BMI may be inaccurate in elderly because due to the osteopenia there may be vertebral collapse. So height is decreased. As height is decreased, BMI may be altered. And medium circumference, what do we use usually in the younger counterpart to assess the muscle mass, this may not be adequate for the elderly, particularly when we try to diagnose the sarcopenia. Eye examination very important because of the visual acuity and the field of vision, because this may be reason for the fall of that person, and asymmetric of the people. As we frequently elderly, we see the asymmetry of the people. Remember, asymmetric people basically is a signs of underlying neurological disorder, particularly the third nerve palsy. But elderly always take the history of cataract operation, because due to the operation there may be asymmetry. So this asymmetry should not be falsely diagnosed as a presentation of the third nerve palsy. Hearing, if you have the hearing difficulty, there will be impairment of the communication. So this can mislead that patient has dementia or sensory aphasia. So sensory aphasia or dementia very closely is the deafness. So deafness to be excluded before stamping the patient as a dementia or sensory aphasia. Respiratory system, one chest expansion, we consider the 5 centimeter chest expansion is normal while we are examining the any patient, but here the chest expansion may be reduced due to loss of elasticity of the ridge. And crepitation, often when we examine the elderly, we see the basal crepitation and we falsely diagnose the patient may have left ventricular failure or pneumonia, but this crepitation may be physiological in the elderly. This knowledge we should keep in mind, otherwise we will overdiagnose pneumonia or left ventricular failure in a geriatric patient. Cardiovascular system, another challenge of the pseudo hypertension because of the presence of atherosclerosis. So if we do not try to understand the atherosclerosis, the pseudo hypertension, that means often will be diagnosed by us. We falsely, spuriously will diagnose the blood pressure very high, and we will go on increasing the drugs after drug, antihypertensive drug. But actual patient's BP is not so high. So we should have the knowledge of the pseudo hypertension. Otherwise, falsely, just as the BP is not controlled, we will go on increasing the drug, and patient will develop the postural hypotension and can develop fall and hip fracture, what happens in the case number 2. So also postural hypertension very common because elderly often have the autonomic neuropathy. And another 2 points you remember, one is the S4, one is the ejection systolic murmur in the aortic area. This is S4 in the elderly is physiological. S4 in the younger patient is pathological. S3 in younger patient or in a child is physiological. S3 in older patient is pathological. So this is we should keep in mind. Gastrointestinal system often become difficult to examine because of the dyspnea, kyphoscoliosis, and parorectal examination we often do not do in a younger patient. But remember, elderly patient, this is not, particularly if the patient has concomitant anemia. Anemia patient in a elderly is a red flag sign. We should not leave it. It can be the manifestation of so many underlying serious disorder. And so parorectal examination is very important in elderly to exclude the rectal carcinoma. Neurological disorder, another very challenging because often patients have the sensory aphasia, and I told deafness to be excluded, and dysarthria. Dysarthria can be from the loss of teeth and often misdiagnosed. There's patient loss of teeth, so often misdiagnosed as having the dysarthria. And posture or gait abnormality can be due to some neurological disorder or can be due to the musculoskeletal disorder. The issue of this discussion is we should not overdiagnose, we should not underdiagnose in an elderly patient. And ankle jerk often lost in the elderly in a physiological way, and pain sensation also often exaggerated, often diminished. So these are some physiological, some changes in the clinical findings and history taking, which we should keep remember. Otherwise, we will either overdiagnose or we will underdiagnose in an elderly patient. So assessment of the cognition, second issue I told this is a physical examination, some clues, some important challenges, some tips we should remember while we doing the physical examination. Now the psychological assessment. 4 issues is very important. One is dementia, one is delirium, one is depression, and other psychological abnormality. Dementia means patients have a memory impairment, along with there is a deficiency of other domains like judgment, personality, speech, memory. These are the different domains of the cortex. These one or more domains will be lost, and this is the chronic process, gradually progressive process. But delirium is an acute process. So where there is an acute and fluctuating course of impaired consciousness. But consciousness is preserved in case of dementia. But in delirium, consciousness is lost. So we have to differentiate between the delirium and dementia. Dementia is a chronic process, delirium is an acute process. Usually in elderly patient present with memory impairment, and we should do the test to test of the memory. And most scientific method is the MMSE method. So MMSE, we can assess the how much memory impairment the patient have. But challenge is here it takes the more than 15 minutes time, and patient needs some education. Illiterate patient, MMSE is not very easy to do. Also, it cannot be performed in the busy hospital OPD. So what are the tools we have? We have a Montreal cognitive assessment. This is a simple tool. We can assess, we can apply. This is the time will not permit. This is not so. In another session, this cognitive assessment can be discussed. But Montreal cognitive assessment method, you can very quickly diagnose even the mild cognitive impairment. And another, just I will discuss this thing. This is very important. By few minutes you can do mini-cog. Nowadays is very popular. Just you ask the patient 3 items, 1 pen, 1 watch, 1 spectacle. Immediately you tell the patient to repeat. This is for registration. Then you ask the patient to draw a clock. You ask, he has drawn the clock. You ask, you put the two arrow 7 past 5 minutes past 7. Whether patient can do properly. Then you ask, you remember what are the 3 items I told you. So there is a 3 step, and very quickly can give you the idea the patient have memory impairment or not. If the patient is diagnosed has a memory impairment, then patient should undergo the MMSE test, that is the detailed test, to classify how much the memory impairment patient have and whether it is a simple memory impairment or dementia. Because to be the dementia, along with memory impairment, there should be deficiency of the other domains of the cortex, like personality, judgment, speech, other domains. At least one domain should be impaired. So these are the important issue of the cognitive impairment and geriatric depression scale. Because when we are assessing the cognition or stamping the patient of the dementia, we should exclude patient of deafness along with patient of depression. So we can apply the geriatric depression scale. There is a different scale. Some has a 15 item, some has only 6 item. So by using one of the geriatric depression scale, we should exclude the depression. Otherwise, you will falsely stamp the patient having the dementia. So, cognition is a very important aspect, because our idea is to give the life to the elderly, not the years to the elderly. So, cognition is the most important, or we should do something, some remedies so that the patient's cognition is remain better for a longer period. So, these are the dementia. When we are killing the dementia, these are the causes, not discussing, but list is very important. Some of the causes reversible. Suppose the vascular dementia, Alzheimer is not the reversible. So you cannot do much. But if this is dementia due to the vitamin B12 deficiency or hypothyroidism, this is reversible. So when you are encountering a patient with dementia, first exclude whether it is a reversible or irreversible dementia. Because reversible dementia, you can give life to the patient. And functional assessment, regarding the functional assessment, 2 basic functional assessment, 1 basic activity of daily living and instrumental activity of daily living. Instrumental means patient can do the shopping, patient can do the banking, patient can do the gardening, and basic daily living means patient can toileting, patient can do their own cooking. So basic activity. Our idea is patient should have the instrumental of daily living is okay. So this is our target. Every elderly should have the good instrumental activity of daily living. And gait malaise, very important, geriatric giant. This, in every elderly patient, you should identify among whether patient have any of these geriatric giant. This geriatric giant means if any of these patient, any of the symptom present in the elderly, patient's morbidity will increase. As the patient morbidity will increase, lifespan will curtail. And more important, patient quality of life will be impaired. So geriatric, one of the 6 geriatric giant, in every visit, you have to be keeping watch whether this patient have. Assessment of the fall because these 2 patients present with the fall basically happens due to these 3 reasons. Intrinsic factor, environmental factor, and situational factor. Fall in the elderly often is considered due to the aging process. But I told it can be the presentation of very serious underlying disease. And these are the 3 issues. So if you can exclude the environmental and situational factor, you should investigate the patient thoroughly to have whether patient have any intrinsic real disease. And these are the tests, these are the research-based tests we cannot perform regularly in the clinic, but these tests, very important tests, we can do in the daily clinic, and we can, by the scoring, we can categorize which patient have the high risk of fall, because in that patient you have to give the fall prevention therapy, because elderly often is osteopenic. If there is single serious fall, there will be hip fracture, patient will be bedridden. So these are the tests. So this protocol you remember, if the elderly come with the single fall, you may not do any investigation. Just give some advice of the fall prevention. But if the patient come with 2 fall in 6 months, this is called recurrent fall. Recurrent fall should be investigated thoroughly. But same patient come with 2 fall in 1 month, this should be admitted immediately. And this is a red flag sign for the elderly. So recurrent fall means 2 fall in 6 months, should be investigated in OPD basis. But if the patient has 2 fall in 1 month, it is a red flag sign and should be investigated as an inpatient basis. So this is the importance of the fall. I'm not going. This is a 4 square test. Patients start working from here to here to here to here. Again, we will go back. In how many seconds patient can do, you have to calculate. And this is the tug. Patient will sit here, put a mark here 10 meters away. Patient sit, stand, walk, again go back and the sit. In how many seconds this happen, you have to calculate. If patient can perform below 12 seconds, that means patient's fall risk in near future is low. But if the patient take more than 12 seconds to go here, come back here and to sit, that means patient fall risk is very high. You assess properly, give some fall preventive measures, otherwise there will be fall and hip fracture. Frailty, we are coming almost to the end because you are all hungry. Frailty, this is very important. Frailty is not a particular disease, it is a syndrome complex. Frailty means patients, there is a loss of patient's capacity of each organ. When there is a minor stress or minor illness, patient functional reserve of all organ decrease suddenly and patient becomes seriously ill. So it is not a heart attack, it is not a stroke, it is not a pneumonia, but it is a syndrome complex. All the capacity of the organ has decreased. Now patient have some diarrhea or some electrolyte. What we diagnose the metabolic encephalopathy. Frequently we stamp the patient as a metabolic encephalopathy. This is basically frailty, because now the patient cannot withstand the simple infection and become unconscious, delirious. This is called the frailty syndrome. Frailty means, but once the patient is frailty, patient lifespan is curtailed and mortality is very high. So you have to diagnose the patient in pre-frailty area. That is very important. You have to diagnose the patient in the pre-diabetic time. So also the pre-frailty. These are the criteria of the frailty, Fried criteria. So you sometimes, at least once in a year, you have to do this test and you have to diagnose when the patient has in the category of the pre-frail. If the patient has pre-fail, you give the specific measure that is beyond today's discussion, and you save the patients of the organs deterioration so that patient, the elderly, can withstand the illness or infections. So these are the frailty and other geriatric problems: incontinence, failure to throb, sarcopenia, anorexia, multimorbidity, polypharmacy, very important and precious show. These are the issues you have to keep in mind. So social issues is the history of the caregiver take, economic issue, loneliness, occupation, household condition, and overall, this is called the comprehensive geriatric assessment. It is not the simple, the physical examination of the patient. So you are doing the physical examination, you have done the functional assessment, you have done the social assessment, you have done the psychological assessment. So together this four is called the comprehensive geriatric assessment that you have to do in every elderly. So in elderly, in a younger patient, this is the diagnostic format. One anatomical diagnosis, pathological diagnosis, etiological diagnosis with complication. But in a diagnostic format, elderly, you have to first mention this, then comorbidity, whether patient have any geriatric giant, other age-related problem, any social problem, economic problem, prescription and modification. This is the standard format of elderly. Just one day back, I went to Australia. I visited a hospital. One Indian doctor was working in the geriatric field. I asked him, India, we do not do. We are concentrated only these two parts. But every patient, they do this format. They follow this format. The entire format is ideal when you are dealing a geriatric patient. So lastly, we are coming to the case. This presented with 2 fall in 1 month. So this is a red flag sign I told. Patient should be admitted and patient was diagnosed. The patient have the pneumonia. So what is the diagnostic format? Patient have recurrent fall due to left-sided pneumonia. This is the pathological diagnosis. Comorbidity, post-severe, geriatric giant, nil. Other age-related problem was osteoarthritis, social problem, living alone, economic problem, retired but good income. Prescription modification not required because patient used to take only omeprazole and some inhaler SOS. Case number 2, patient anatomical pathological diagnosis of fractured neck femur and postural hypotension. Comorbidity is hypertension, geriatric giant, fall in the elderly. Other age-related problem, atherosclerosis, social problem, no social problem, have caregiver, economic problem not significant. Prescription modification, definitely patient needs the prescription modification because patient is taking too many antihypertensive drugs and that causes their postural hypotension and fall and hip fracture. So this should be the diagnostic format in every elderly. Abraham Lincoln is correctly told that in the end, it is not the years in your life that count, it is the life in your years that counts. Thank you. Thank you all.
Thank you, sir. There will be no question answer for this as it is an oration. I welcome Dr. Arvind. Welcome to Jamshedpur. Okay, friends, may I request the chairpersons for the memento to the speaker. Sir, please. Can we have mementos for the speaker and the chairpersons? Request both the chairpersons to hand over memento to our speaker, Dr. Paul. Dr. Virmani, sir, how can you leave us? Please be with us. आप कहाँ जा रहे हैं? Thank you. Now may I request Dr. Paul to hand over memento to both the chairpersons. Thank you, sir. Another memento for our chairperson, Dr. R.K. Sinha. Thank you, sir. So, loud round of applause, pre-lunch session. We break and we break for lunch for half an hour. Time मिला लीजिए. आधे घंटे में हम वापस आ रहे हैं. I know it is a bit late. काफी भूख भी लगा है.